right, well, welcome everyone. I am Christy Cahill. I am the Executive Director of the Colorado Cancer Coalition, and I want to welcome you to day 2 of the Colorado Collaborative on Lung Cancer Screening. We had an amazing session last Friday, and I'm looking forward to this session today and continuing to learn and share best practices. So thank you all for coming today for session 2. So some of the stats you saw last time. So in a state where 23 people die a day from cancer, and in a state where cancer is the leading cause of death, and where lung cancer is the leading cause of cancer death, how do we work together to prevent it, find it earlier, treat it better, and improve the quality of life for survivors? By you coming here today and engaging in the coalition work and engaging in the work you do on a daily basis, you are a huge piece of that puzzle and helping improve the lives for Coloradans touched by cancer. Just a little bit of background, the coalition has 2 main purposes. We provide a lot of education and networking for people that work in the oncology space. And then we also provide a lot of resources for survivors and caregivers. So if if you have any cancer related questions, you can come to the coalition and we can direct you to the right place. So today we're going to continue talking about addressing challenges and barriers in lung cancer screening. Then we'll have a short break, and then we'll talk about some unique initiatives in Colorado. And then we will look ahead to where we're going, as well as have 3 patients share their stories at the end on a patient panel. And I just want to say thank you to the University of Colorado Cancer Center and AstraZeneca for helping support this collaborative. Just a few quick Zoom tidbits, which I think everybody's pretty familiar with Zoom now, but be sure to rename yourself so we know who's here. Use the chat function if you have questions, and then if we have time, you can also come off of mute and ask questions during the question and answer session. For the most part, please stay on mute. You can have your video on or off, it's up to you. And then again, use chat for Q&A, and we will be sending an evaluation at the end. So please do let us know how we can meet your needs going forward. So I'm going to stop my share and turn it over to Debbie Dyer to get us started today.
And hello, everyone. It is just such a pleasure to be with you today. And I am delighted that we have this array of speakers for you, and we'll be addressing a lot of different topics as Christy outlined. And our first speaker today is Dr. Kyla Crofta, and she is a family physician and medical director of preventive screening for Kaiser, Colorado. And she is going to give us some highlights and insights into referring provider concerns. So Kyla, we're really interested to hear what you have to say.
You're on mute, Kyla.
There we go. Are you able to see my screen okay as well?
Yep.
Perfect. Well, thank you everyone for having me. Today, we're just going to talk about some of the referring provider barriers. And most of the time on these slides, I've used the word PCP, and I'll probably default to saying that, but I fully recognize there's a lot of other people that are referring. So I know our OB-GYN colleagues often will do this. It may be a pulmonologist. So I really think a lot of these concerns, even though we're focusing on the PCP, really apply to a lot of different referring providers. So in talking to PCPs and other providers, we've learned about a lot of different barriers, and many of these came up last week already. And so we'll just go through some of them, and then I picked out a few to focus in a little more detail today. So one of the things we hear the most often is just a lack of time and the competing demands during short primary care visits. The docs are often unsure about where it belongs or what type of visit should this fit in or where in the visit. And then there's a lot of trouble identifying who is eligible and just remembering to discuss this, especially at point of care, quickly figuring out, is this a patient who qualifies? And then there's some lack of awareness and education and misconceptions about the risks, the benefits, and the changes in guidelines. There's inconsistent coverage, as we've talked about, especially with the new guidelines, differences with Medicare. There's definitely a fear of the shared decision-making requirement that we hear about often. There's concerns about potential incidental findings. How's the patient going to deal with that? What extra work is that going to put on the provider who's ordered the CT scan? There's a perception that there's a lot of lack of patient interest too. I think a lot of providers think your patients just aren't going to be interested in this, and so it's not worth the time. It's sometimes a difficult thing to discuss. There's a lot of stigma, there's patient perceptions. It's not as easy as maybe talking about a mammogram. Then there's a fear about the difficulty and the time it's going to take to coordinate next steps. So whether that's following up on a nodule that's found, even just the reminder for an annual scan next year, it's creating more work. And then there's concerns that really focus more on the patient that get extrapolated to the PCP. So concerns about the costs the patients are going to occur, especially if there is follow-up that has to happen. Concerns that patients are going to put up a lot of barriers that the PCP doesn't really know how to help with. So whether that's transportation or not being able to get time off or it being too far away. And I think those lack of resources are big. So scans for patients that are in further out areas, rural areas, they may have to drive. Getting to a specialist when they need follow-up might be really far away or time consuming. So let's dive into a few of these. So one of the biggest ones, the lack of time. We've had a tough couple of years. We've added COVID to the mix, and it just feels like every primary care visit that was already jam-packed, we now have to talk either about vaccines or the COVID you had last week, or is it safe to go visit grandma for Thanksgiving? And that just takes up that precious little bit of time we used to have. So I think my advice on the time to PCPs is this is actually faster than I think you think it's going to be. A lot of the time, these discussions are done in just a couple minutes and they don't drag on for the full 20-minute visit. I think the one thing we learned from pandemic is virtual care. This is a perfect thing to talk about over the phone or a video visit. You don't need a 20-minute in-person visit. Patient had to take off work to come in. You really can leverage your virtual care here. And then I think it's okay to not finish it the first time you bring it up. So especially if a patient does want to have a more in-depth conversation, just set the stage. So introduce the topic and say, could we set up a phone visit for 2 weeks from now? Or how about when you're coming back in 3 months to check in on your diabetes? Can we talk about it then? Why don't I send you with this handout? So read a little bit about it, do some thinking, talk with your family, and we'll talk more in a few months. And I think that's okay. We always get the feeling we have to take care of absolutely everything in one visit, and that's just not realistic. And then for those who are supporting the PCPs, how can you help them with this? So I think one of the biggest messages is take stuff off the plate of the PCPs. As much as you can do for them so they can focus their time on a couple little steps, that's helpful. Leverage technology. Help your PCPs by getting them more technology. Use other members of the care team. Who else can help with a piece of this? And then outreaching patients proactively. So maybe if you're identifying who might be eligible for lung cancer screening, outreaching them and saying, let's set up an appointment with your PCP to talk about it. So that visit is focused on lung cancer screening instead of lung cancer screening being the afterthought in a busy visit. And then having everything in one place is really helpful. So at Kaiser, something we have is a smart set. It's in our electronic record. You open the smart set, has everything there. So it has all the clinical guidance to help remind your PCP who is eligible, what they need to do. It has a CT order, has a referral into our lung cancer screening program. It has a link to a shared decision-making tool. It has patient handouts. It has scheduling instructions. Literally everything is in one place, so I can move much faster through that visit and really focus my time on the conversation with the patient and not all the logistical stuff. And some of these things we'll talk about in these next slides in a little more detail too. So shared decision-making. I think this feels like a barrier because it's a requirement, but it really shouldn't be. I mean, as a PCP, this is what we do all day long. Half our conversations are shared decision-making. So you're talking about which blood pressure medicine you're going to start, or which birth control option, or is your abdominal pain bad enough we should get the CT today, or can we wait another week and see what happens? It's really just part of our practice. I think putting the label on it is what's made it hard. And there's lots of tools out there to help you. So there's all these shared decision-making tools, and we're lucky we have one built in for us. But if you don't, honestly, it's fine to Google. I Google stuff in front of my patients all the time. I tell them, like, oh yeah, there's this great visual I want to show you. And I Google and I pull it up. I mean, even if you don't know which one you're about to pull up, just make sure you're kind of quickly looking. It's a reputable source and you'll be fine. And then just keep it simple. I mean, a shared decision-making conversation doesn't have to go into the finest detail of 1 in 1,000 have this risk and 1 in 100 this and go through every piece of it. Some patients might want that, but most don't. You can talk in a much more general sense, talk about there's some risk. There's risks of radiation. You know, there's a chance we're going to find a nodule. It's really common. Often they're not a big deal. This is what's going to happen. You don't have to go into every little detail. You can read your patient and figure out how far you want to go. And like anything we do, the more you do it, it gets easier. We all have those things that we can talk with our eyes closed, doing 3 other things. We've said it 1,000 times. And then we have those things in medicine where maybe we only see it once or twice a year. And so we fumble through it a little more. And that's okay. You just keep practicing, you'll figure it out. And then how can other people support the primary care providers in this? I think giving tools. So like I said, we have that shared decision-making tool built in. If you can electronically build it in, great. If you can have a laminated copy that when you know your doc is going to talk to a smoker, pulling it out, putting it on the desk so it's ready to go for the doc, super helpful. And then pre-work for patients. So if you're scheduling patients ahead of time just to talk about lung cancer screening, can you electronically or snail mail them a shared decision-making tool? Or even if it's just when you're getting them in the room and they're waiting for the doc, handing them that laminated thing, anything you can do to save the doc 30 seconds will help them out. So this is one of the biggest barriers, I think, is figuring out who's eligible, and especially at the point of care. So if you're in this visit and doing 20 things, how do you remember to also check, are they eligible for lung cancer screening? And how do you quickly calculate that if you've got to figure out, okay, when did they quit and how many pack years and how old are they? It seems simple when you do it all the time, but when you're fitting that in with 20 other things in a well visit, that extra 2 minutes to figure it out is just too much. And so, and then figuring out where it fits too in the visit, I think that's where we lose a lot of opportunity, is it just feels complicated. And I think there's some different ways around this. So it depends a lot on what your resources are, what kind of medical records you're using, but there's definitely some things that PCPs can do. So you can add prompts to your templates. So if you have a section in a wellness visit that kind of talks through, maybe you have a chart or some kind of drop down that goes about mammograms and colonoscopies, add your lung cancer screening there. And then figure out where it fits for you and put it in your mental flow. So if you want to talk about it right after mammograms, maybe for the first few months you're doing this, put a little sticky note, like an actual little like white ribbon sticky note or something on your computer to remind you. And then as you do it, it'll just naturally fit into your flow. And I think there's different places where this can fit. It can fit when you're talking about cancer screening and prevention. It can fit when you're talking about tobacco history, when you're collecting that history, or when you're talking about quitting smoking. And then I think this is where you can lean on your team, train your staff to help figure this out before you even enter the room and flag it for you. And I think this is a big area where we can really support our PCPs. So leveraging technology. How can we do this? And I think this is one thing that Kaiser does really well. We actually calculate behind the scenes using Epic if the patient is eligible for lung cancer screening, and we create something called a care gap. And so we use care gaps for everything, whether you're due for your mammogram, your A1C, we have a care gap that is, are you eligible for lung cancer screening? We look at those pretty much every time we see a patient. So instead of me having to go do a calculation, it's popping up on the screen next to your due for a mammogram is, I should talk to you about lung cancer screening. That just saved me 2 minutes right there and reminded me to do it. And I know that since I'm in this system with these gaps, I do a much better job than I did where I worked before. And then capturing an accurate tobacco history. Sometimes it's easy. Sometimes a patient says, I smoked for the last 20 years, 1 pack a day. There you go. You're done. You're still smoking. Other times your patient could take 5 minutes to tell you their tobacco history. Well, I was in college and then I quit because I was pregnant, but lost it again. And so if someone other than the doctor can get all that information first, do the calculation, enter it in the system or write it on paper, whatever it is, you've just left your doc with a few more minutes to talk about the lung cancer screening. And I think I mentioned this before, but pre-identifying patients. So don't wait till you're in the moment. Maybe you don't have the resources we have at Kaiser to fully identify everyone, but maybe it's part of schedule scrubbing. So maybe if someone's going through your schedule before the day starts or the day before, one of the tasks they have to do is look at the smoking histories and figure out if the patient might be eligible, or if you're missing a smoking history, flag that it needs to be collected. And I think with technology, especially with Epic, I know many systems are on it, the options are there, but it's expensive and there's always competing demands, right? Everyone in your organization wants 50 new things from the medical record. And this is where you can help the PCPs lobby for that money, lobby for the priority to get these things done. Sorry, guys. And then the difficulties coordinating and ensuring follow-up and the annual scans, it can feel like a lot, especially if you're lacking some of these electronic things. And so I think for the PCPs, really try to lean on your teams, figure out who can help you with this, because at the end of the day, it's not toposcope work to remind someone to get their CT. Find out what people are doing already to help you. I think sometimes things are in place that we just don't even realize. I'll be honest, even at Kaiser, where we have some great stuff, our PCPs don't always know what we're doing for them behind the scenes. So find out who's helping you and what they're already doing. Find out the imaging centers that you're going to use. What do they handle? Do they send any reminders if a patient are due? And then use technology ticklers. So again, everyone's system's different, but you can send messages to patients in some systems with future dates. So when you're reviewing their scan and it says they're due in 3 months, you can write them a little message now, but put a send date for 3 months later to remind them. And I think it's okay to leverage your patient a little bit. Have them try to line their scan with something that might help them remember. So do their scans in their quit month date, or do it right when they do their mammogram or with their birthday, and have them put reminders. A lot of people keep their same electronic calendar or phone for a long time. So it's okay to tell them, hey, pop out your phone and put in when you're due next. The more reminders someone gets, the more likely they do it. And I think, again, this is one of those places where really, if you can take this off the PCP so they know this burden isn't on them, and they're only kind of there as that like last push if the patient's kind of hesitant, it'll really help. And so if you have stuff in place already, make sure your PCPs know about it. If you get a new person in their organization, make sure it's part of their onboarding. And then navigators, I know a lot of places have navigators. This is huge here. This is work our navigators can absolutely do, helping remind and coordinate. And then the reminders can be automated. They can be semi-automated. Epic has a lot of great stuff. We're pretty lucky. We have reminders that go out when someone's due for a follow-up scan. They get text messages, they get electronic reminders, they get letters, and no person's involved in any of that. That just happens because of technology. The end step, they end up on an automated list if they haven't shown up, and then a person gets involved and starts making calls. So the technology's out there. Again, you got to lobby, you got to get the money, you got to get the resources, but it's there. You can also go old school. When I was in high school, I worked in a dental office, and when a patient would come for their check and they're about to leave, we would fill out this little postcard that's like, you're due for your next checkup. And then we had a little filing box, and each section was a month. We would put the little postcard in that month. And when that month rolled around, we just pulled up the stack of postcards. They were pre-stamped. We threw them in the mail. And so it's pretty old school, but it works. There's ways to do this, even if you don't have the technology. And then the orders piece of it, if you can take some of that off the docs, it's great too. I mean, we're super lucky. I never have to order a follow-up scan. They're actually automated. I realize a lot of places can't do that, but how about pending the orders and getting cosigns? Is there anything you can do to just not make the docs as responsible? And then the patient barriers around resources and logistics. So whether it's cost, it's getting follow-up with a specialist, it's taking time off work, it's concerns about the cost of the follow-up scan. I think it's really tough for providers because we often feel like we just don't know how to solve these problems. And so I think some of the things that can be done is having one resource. Sometimes we get overloaded with, well, there's this organization and this place funds and this is doing this event. And When we're taking care of 500 different medical conditions, we can't remember all of that or even remember where we stored that information. So give us one person, whether it's a navigator, a social worker, who do we go to? Just one person instead of 500 different things. And I think that'll really help us out. And then I think from the PCP standpoint, when you hear these barriers, I mean, you listen, you acknowledge it, you give your empathy, and sometimes you probe a little. This is where the beauty of knowing your patient, knowing when it's okay to kind of push back a little. Sometimes these barriers, the patients can come up with their own solution. And I think it's okay to do a little bit of that. I had a patient the other day that had put off a procedure and she really needed because she didn't have any help and she would need help recovering. We finally got her to say, well, my one daughter is a teacher, and so she has summers off and has more time. So I might not be able to do it quite yet, but maybe I could do it this summer when she could help me. And so sometimes just a little creativity, a little push, and you might get somewhere with it. And then offer a note. If your patient's worried, they have to drive a long way, they need the day off to get their CT, I'll write you a work note, no problem. This is important. And then some of the other things are just lobby and advocate. So get better coverage on our insurance plans for follow-up. It's a huge barrier. Get more consistent coverage with the new guidelines, get Medicare on board. And then expand access for our patients. So imaging centers have weekends, have evening hours, resources for transportation and even lodging. If patients have to go really far away, they may not be able to do it in a day. So lots of things we can do to support our PCPs and really our patients there too. And so my main takeaways, try to minimize what the PCP has to do from the start of the process to the end of the process. Whatever you can take off, take it off, and make sure the PCPs know you're taking it off. Let them focus on what they do best, talking with their patients, capitalizing on the relationships and the trust. Leverage and lobby for technology. Don't make the PCPs do it. Ask for the money for them. And then it's a team approach. Insert, optimize other care team members in the process, whether it's navigators, it's rooming staff, it's nurses in your clinic, it's social workers. Get other people involved and secure more resources and support for the challenges that patients face. And that's it for today. Thanks, everybody.
Thank you so much, Kyla. I love listening to you and all of your really, really practical, sensible ideas. So I always learn something every time I hear you. I am going to go ahead and share my screen now because I am going to provide the next set. Let's see, Christy, I think it's telling me only you can share.
Oh, I will make you co-host. I thought I did that. Try now.
Okay. All righty. So it's my pleasure today to talk to you about the incidental findings on lung cancer screening CT. And this is one of the areas that we have heard is a barrier. And we know that there's concern on behalf of some of the primary care providers that, oh my God, this is going to uncover a whole bunch of other stuff that I'm going to have to deal with. And then there's also the issue of if we have navigators or program coordinator nurses who help manage the care continuum in our lung cancer screening patients, they feel sometimes uncomfortable about what is in the reports and how do they handle them, those findings. So I'm delighted to tell you about a newly published quick reference guide. This is from the American College of Radiology, and I work on a committee that helped develop this guide. I do have some disclosures here to share with you. And my objectives today are just to provide some highlights from this new quick reference guide. And then also I will be giving you the website where you can access this guide. So this is what the guide looks like. It has 2 pages, so it's possible to print this off front and back. And you can use this if you are in that situation where you need to better understand maybe what recommendations the radiologist has provided, or if maybe the recommendations aren't completely clear, or if you want to be able to talk about this with a patient and be able to sound like you know what you're talking about, and so forth. This guide has been 2 years in the making, and it really included a lot of input from radiologists, from content experts, from pulmonologists, and primary care providers. We tried to make the language here as clear as possible. And then also we did a trial with navigators last year, and we had about 45 navigators that participated in evaluating the document. We did get feedback from them and made some improvements in the document to make it more understandable. All of the recommendations are based on either white papers or references in the literature or content experts. So this is what it looks like, and I'm going to be going through and highlighting parts of this. Now, first of all, it is important to understand that this guide doesn't include every possible incidental finding. It describes really mostly the common ones or the most concerning ones. It does identify findings that are insignificant and significant, and those that are significant are determined typically to be actionable, meaning there is some sort of next step. And then it outlines the strategies for those next steps. So for example, something that we very commonly see is coronary artery calcification. As in lung cancer screening eligibility criteria, we know that patients had to have been either persons who smoked previously or currently smoke. Then we certainly are not surprised that we're seeing coronary artery calcification. So the radiologist does typically describe if this is present, and they will quantify it as none, mild, moderate, or severe. And if there is any coronary calcification present, then it is recommended that the primary care provider evaluate the patient for atherosclerotic disease, what their risk is. In general, moderate or severe calcification is considered significant, and the provider may want to put the patient on a statin drug or ask them more about any potential symptoms that may indicate they really do have underlying significant coronary disease. So what does this look like on the CT? Of course, the CT is a cross section through the body, and this is an image, a cross section through the heart. And the coronary arteries come off the aorta, and the main coronary artery comes off and branches into the left anterior descending and the left circumflex coronary artery. Well, in this particular patient, we see really a moderate amount of coronary calcification here in the left anterior descending coronary artery. And in this patient over here, we see a large amount. So this is severe coronary artery calcification. And so it is really important that the patient understand. And if you have the chance to show them their images and share this with them, this can make a big difference. There are reports in the literature, in particular with coronary calcification, that if you show a patient this disease, this calcification, it can actually influence lifestyle changes. And in fact, it may also be appropriate to put the patient on some sort of statin therapy. Now, aortic aneurysm is another potentially significant finding, and the radiologist may comment and give you the actual size of the aorta and say that it's enlarged, or they may describe something as a focal aneurysm. And when we see something focal, there is actually an increased risk of rupture. And the recommended action for an aortic aneurysm is to make sure the primary care provider knows about this and that they do some sort of surveillance or maybe even consider a cardiology consult. So what does this look like? So on that CT, again, now here we're doing the cross section through the body. We are above the heart, but here is the ascending aorta. This is the descending aorta most posteriorly, but here you can see the discrepancy in size between the ascending and descending. This is a large ascending aorta. This is larger than 4.2 centimeters, so it would be appropriate for this patient to get some follow-up imaging on some sort of a regular basis. Now, this one is probably of more concern. This is the arch of the thoracic aorta. It's the top of the aorta in the chest. And here's this bulge coming off the arch of the aorta. This is a little more concerning. And so it may be appropriate to do a contrast exam and follow this up and see what this really looks like and if there's maybe more increased risk of rupture. It's also common that we see abnormalities in the liver. I think it's really important to know what is considered insignificant or likely benign versus something that's more concerning. So simple cysts, if the radiologist describes that, those are really considered to be okay. You don't have to worry about those. A nodule less than 1 centimeter is probably okay and likely benign. And frankly, if a patient complies with their annual screening, you're going to get a chance next year to look at this same nodule and see if it has changed at all. But a nodule less than 1 centimeter is considered likely benign and doesn't need any immediate follow-up. Now, if there is a nodule, a soft tissue nodule or mass greater than or equal to 1 centimeter, it is recommended that the patient go on and have some further evaluation. And what is recommended is a contrast enhanced abdomen CT or MRI. And then another finding that we're seeing more and more is fatty liver or infiltration of the liver with fat. Some radiologists will describe it as hepatic steatosis. And this is really considered a significant finding now. And certainly if we see anything that looks like cirrhosis, where the margins of the liver are irregular, we recommend that the primary care evaluate the patient. Ew. I'm not advancing. Here we go. So here's an example of cysts. These are cysts that we don't have to worry about. This is a blow-up image here of the image on the left. So the radiologist typically will do a density measurement, and if it is compatible with a cyst, they would describe it that way. A cyst, if it's a simple cyst, does not need further workup. Now that is then different than this. Here is this abnormality in the edge of the liver. Here's a close-up view, and it is low in density, but it's not as low in density as those cysts that I showed you. And in fact, this needs further workup. And this patient went on to have further evaluation, and it turned out that this was really a vascular lesion, a hemangioma, and it was not malignant. It did not need to be resected, but it did need further workup. And then I mentioned the fatty liver. And so it sometimes may be subtle to recognize this, but the liver, if it's low in density, and especially if it's lower in density than the central part of the liver or the spleen, then the radiologist can call this as fatty liver infiltration. And we are knowing that the patients can have metabolic syndromes and other problems related to having a fatty liver, and we certainly want our providers to know about this. Now, the adrenal glands, most people don't think about them that often. And in fact, they're probably, the findings in the adrenal glands are not significant. Actually, having a significant lesion in the adrenal glands is uncommon. but having insignificant lesions in the adrenal glands is sort of common. Many patients can have adrenal calcification, maybe related to old trauma, and calcification in the adrenal gland is okay, not to worry about. A nodule that is fat density is likely an adenoma, and you don't have to worry about that. A small soft tissue nodule in the adrenal gland also does not need further workup. It's considered okay. And a nodule that's been there stable for greater than a year is okay. But any other nodular mass would need further workup with a CT or MRI. And here is an example of an adrenal adenoma. The adrenal gland is actually positioned above the kidney. And so here is this round lesion in the left side of the abdomen. And when we do Hounsfield units measurements on that, we find out there's fat density there. And this is really considered then insignificant, and we don't have to do further workup. Now the kidneys, it's not that common, but it also certainly does happen that we can see small renal calculi. And if they're non-obstructing, those are considered okay. And a simple cyst in the kidney is considered okay. But any other soft tissue mass needs an abdomen CT or MRI without and with contrast. And so here's an example of one of these little tiny calculi that can be in the kidneys. There's no evidence that this is causing any kind of obstruction to the urinary system, so this is considered okay. Now here is a simple cyst projecting from the top of the right kidney, and if it is water density, and the radiologist hopefully can report in their report if it is a cyst or if it's water density, and that is considered okay. Now, the difference here is we have a mass in this left kidney here. This is soft tissue density. This is an irregular portion of the kidney projecting out from the kidney. And this is something that needs further workup. And this particular patient that was in our screening program ended up having this as found as a renal cancer incidentally, and the patient has been doing very well. It was an early stage renal cancer. Now, the thyroid is another area that we commonly will find abnormalities. And in older patients in particular, we can see goiters, and those are usually enlarged heterogeneous parts of the thyroid with calcifications, and those are considered okay. A nodule less than 1.5 centimeters is considered okay. A nodule greater than 1.5 centimeters, or if it has suspicious features, needs a follow-up ultrasound. Here's an example of a goiter. It looks like this large mass. It looks kind of scary, but in fact, it has a typical appearance for a goiter, and believe it or not to worry. Now, here is a thyroid nodule that is benign in appearance. It's small, it's hypodense, not to worry. In contrast to this lesion, which is very heterogeneous and needs further workup. Now, finally, I just want to talk about the lungs. It's important to recognize that many of the patients getting lung cancer screening have underlying chronic obstructive pulmonary disease. They may have bronchial wall thickening and emphysema. Those are actually expected findings. And so we don't necessarily worry and feel like we have to do something right away to address that. They certainly may benefit from discussion about their COPD findings. But fibrotic interstitial lung disease can be recognized on lung cancer screening CT, and we need to report that, and it is recommended that those patients have a pulmonary consult. And so here's an example of a patient with bronchial wall thickening. This is a patient with marked emphysema. So these darker areas in their lungs are emphysema. And here's a patient with lung fibrosis. And so that patient here with the lung fibrosis certainly would benefit from a pulmonary consult. Now, there are a couple of interstitial lung diseases that are actually smoking related. These are rare, but we do see them. And these are patients, one of the smoking related lung diseases is pulmonary Langerhans cell histiocytosis. And there's these unusual, bizarre shaped cysts and nodules in the lungs. And there's another smoking related interstitial lung disease called desquamated interstitial pneumonia. And there's typically these areas of haze and some cystic change in the lungs. So in summary, the incidental findings on lung cancer screening CT can be challenging. Some are insignificant and need no follow-up, where others are significant and need further follow-up. It is important that the referring provider and patient are notified about significant findings so the next steps can be clearly outlined. And to get a copy of that handout, I have the reference right here, and we'll make sure to include this in your follow-up materials. So thank you. And I will stop sharing. And it's now my honor to introduce to you Jim Fenton, who is going to be discussing with you about the importance of the multidisciplinary team in lung cancer screening. Jim is a pulmonologist with National Jewish Health and works at our South Denver office and helps with the lung cancer screening program with the Swedish system.
Good. Thank you very much, Debbie. I think you did a great job, actually, of describing why there is so important to have a multidisciplinary team. You went through a lot of complex issues, and that's why we need that. I think we all agree that a multidisciplinary team for lung cancer care and for management of lung cancer screening nodules is very, very important. Debbie asked me to talk a little bit about that today. There we go. And while we all agree that having a team approach is helpful, I think we all know that. The World Health Organization also recognizes that. They recognize that multidisciplinary care is definitely an essential part of the delivery of high quality patient care. You know, medicine is getting so complicated in all different areas, but especially in lung cancer care. The WHO says that it provides an important role for improving healthcare services and outcomes, probably just by getting us all in the same room together and improving communications. So and likewise, the NCCN guidelines, actually now about 10 years old, came out. When it first came out, lung cancer screening was in its infancy, and they stated that really lung cancer screening should be a part of a program of care and not be performed in isolation. At National Jewish, the National Jewish Multidisciplinary Lung Cancer Screening Team consists really of 2 navigators and 6 advanced practice providers. These 2 navigators call the patients that are referred for screening. They determine eligibility and do a risk assessment using a Brock calculator. Then they get them set up with the APPs. As I said, there's 6 APPs. The APPs are in charge of doing the shared decision-making. They initiate the smoking cessation counseling as well, because they're certified in smoking cessation as well. The APPs are responsible for being the ordering provider. So they get the results back and follow up on the results using mainly the LUNGRADS protocols that have been established. And but if there's a LUNGRADS 4, it's not just a CT follow-up. Those patients need to be discussed with the referring doctor and brought to a multidisciplinary team. And then from the recommendations of the multidisciplinary team, then the patient is either referred to consultants or a plan of care is outlined at that time. So the multidisciplinary team is extremely important in our lung cancer screening team. And the National Jewish Program is a good example of a centralized lung screening program. That type of centralized lung screening program recruits eligible patients, although some patients are referred into the program. They do the education and shared decision-making visits, along with things like smoking cessation. They perform all the images and interpret the screening studies. That's what Dr. Dyer does on a regular basis. Then they also follow up the exam and track the clinical and outcome data, and then communicates the results both to the patients and to the referrers. Certainly requires a dedicated lung cancer coordinator. Actually, they have a number of coordinators at Main Campus National Jewish. So it does take certainly a team and a team approach to run this centralized lung cancer screening program, which really does it all. Our program at Swedish and the Sarah Cannon Health One program is a decentralized program, probably more of a little bit of a hybrid. Many programs throughout the city and the state are decentralized. And the decentralized program for lung cancer screening is starts out really with the primary care provider or other providers like pulmonary or even OBGYN sometimes can may refer their patients for lung cancer screening. Certainly we will do the shared decision making encounter. Primary care may do that as well. Remember, the shared decision-making encounter is a billable procedure. So some of the primary cares prefer to do that on their own. And besides, they know the patients very, very well and can make recommendations to the patient for the lung cancer screening. Then the PCP will generate an order, but the screening then is not done at there because that's a primary care office. The screening is done usually at a outpatient freestanding imaging center in Denver, such as Sally Jobin Vision, Touchstone Health Images. There's a number of them in the Denver metro area and throughout the state. And then the images are interpreted by the radiology center and then sent back to primary care to manage. So this is an example of a decentralized program. But either the centralized or decentralized program requires a multidisciplinary team. I found in this as a good reference. This is a lung cancer screening implementation guide, how to implement a screening program put out by the American Thoracic Society and the American Lung Association. And it can be found at this website here. So you might look at this website to see, requirements for your screening program, and has a lot of good ideas. So it might be good for folks to take a look at this for their own screening program. So we all can agree that lung cancer care is very complicated, and the first part of this lung cancer care is to identify the patients. And like we said, the referring doc will refer patients into a multidisciplinary program. Patients may be referred in from the lung cancer screening program or an incidental nodule program. At Swedish, we have an incidental nodule coordinator that is solely responsible for finding and determining the incidental nodules on scans from the emergency department, on abdominal scans, all the things that Debbie just went over. And then some of those patients then are brought to our tumor board. We meet weekly, and this is a multidisciplinary tumor board, which reviews active lung cancer, but also suspicious lung cancer nodules. And it really requires a whole team of specialists to make up this multidisciplinary team, lung cancer specific tumor board. And that is really the key to any lung cancer screening program or any lung cancer care program. So this just goes through that if you do have an abnormal lesion, then you may need biopsies and you need other specialists. That biopsy then needs testing, including histologic evaluation, even more advanced molecular biomarker testing. And then you're on to treatment and retreatment and what to do if we need another biopsy. So the multidisciplinary team is very, very important in the care and the direction of patients in this very complicated lung cancer scenario. And a shout out to the nurse navigators, coordinators, counselors, therapists, all the other non-provider staff that makes our lung cancer team, multidisciplinary team, a success. So lung cancer patients are definitely a heterogeneous group, and they really need a coordinated approach. It's been shown that in multidisciplinary meetings, sometimes we have very heated and interesting meetings. Sometimes it's more routine, but multidisciplinary meetings are very, very important because it has been shown that patients have a shorter time interval from first consultation to treatment. They may have the multidisciplinary meetings have been shown to improve preoperative staging. So there's a higher proportion of patients that get full mediastinal staging. We know exactly what we're dealing with because they have had good preoperative staging. And then a lower proportion of patients with unsuspected advanced disease. They get to surgery. We don't have many patients that get to surgery, and then we find that their tumor is more extensive than what we realize. So multidisciplinary meetings have a very important role in preoperative staging. As you can imagine, most multidisciplinary meetings follow clinical guidelines, and you can demonstrate that there's a much higher adherence to clinical guidelines if patients are presented at these multidisciplinary team meetings. We also think there's an overall survival in patients that undergo discussion at multidisciplinary meetings. If you use this stage 3 non-small cell carcinoma, and in whether they were discussed at multidisciplinary team meetings or not, the median survival was significantly improved in those who were discussed at multidisciplinary meetings. This is actually a big difference, 41 months versus 25 months. But regardless, and the difference may be smaller in other studies, but it goes to show you that there is an impact even on survival. This is a good example we had in our conference just recently. This was a lady that presented with a right lower lobe lesion as well as a left hilar lesion into the left lower lobe. The patient had biopsy both on the left and the right by bronchoscopy. Both were non-small cell carcinoma, adenocarcinoma type suspected. But what was interesting about this case was that if you look on PET scan, this lesion on the left was not active really at all. Yet the lesion on the right lung was not active very much at all, whereas the lesion on the left was very active. So it looks, based on the PET scan anyway, that we have maybe two different lesions or two different cancers that are acting in different fashion, at least by PET scan. We had a long discussion about this patient, and do we treat them as metastatic disease, which was the first thought, or do we treat them as synchronous primaries? And I think at the end of the discussion, this patient is going to be treated in a different fashion for synchronous primaries. So multidisciplinary meetings do change management in about half the patient. That may be that the MDM suggests further investigations or a recommended treatment modality, or like in this case, maybe a change in treatment intent. We're going to intend to treat this lady as synchronous primaries rather than as metastatic disease, and that may make a huge difference in her outcome. Regardless, most patients receive more treatment of more modalities if they're discussed at multidisciplinary meetings. And then more often, curative treatment is recommended. That if you put everybody together in a room and discuss the latest treatments, we're usually able to find a regimen that would hopefully be curative. in multidisciplinary meetings, more patients are referred usually for neoadjuvant chemotherapy. We discuss the patients ahead of time before they get surgery, and a lot of times it's best to have them have neoadjuvant therapy, chemotherapy for usually stage 3 or N2 disease, and then we'll reevaluate at another team meeting to make further recommendations as to whether surgery is appropriate or other treatment. So chemotherapy is recommended more often based on multidisciplinary team meetings. And so is radiation therapy, especially patients are more likely to undergo concurrent chemoradiation therapy, especially for stage 3A disease or limited small cell. And that comes from a VA registry. So bottom line, radiation therapy utilization also was increased, actually doubled if patients were discussed at multidisciplinary meetings. And this is another example. One of my partners called me the other day and he said, yeah, this patient was admitted for neurologic symptoms, probably brain metastasis. And he said, gosh, she has, large amount of tumor within her mediastinum and the right lower lobe here. And we need a bronchoscopy. We need a general anesthesia and a bronchoscopy. And I said, well, let's go ahead and do a PET scan, and then we'll present her at our multidisciplinary tumor board, and then we'll go from there. I suspected she was going to have a high burden of disease. You can see the tumor here in the right hilum and right lower lobe, but she also has other areas of disease as well. And on the PET scan, there was a soft tissue nodule in the upper part of her left side of her back. It was very easy to biopsy under ultrasound using just local anesthetic. So we were able to obtain a biopsy very simply, safely, without general anesthesia, because we discussed this patient at a multidisciplinary tumor board. So just good examples of some of the things that are discussed at tumor board and why they are important. We know that multidisciplinary tumor boards improve the time between diagnosis and commencing treatment, at least most of the time. You can imagine that if you have a very complicated patient, that they might need to see a number of different specialists. So some of the studies actually showed that there was a little bit longer time between diagnosis and treatment, but it was non-significant. And certainly there were timeframes with it well within the recommended guidelines of time to treatment. And patients seem to be satisfied with the multidisciplinary tumor board, multidisciplinary meetings. 98% of the patients surveyed were highly satisfied, especially that their case was discussed at a team meeting. I call it a team meeting. And if you look at centralized programs, now this is centralized lung cancer programs, not just centralized screening programs, but patients were definitely more satisfied with their care. They felt that there was better communication, which there is. We communicate better when we're all in the same room or all at least on the same Zoom call now. And they felt more comfortable that the physicians were collaborating. I don't know how many times the patients say, well, hey, have you talked to my primary care? Have you talked to my other specialists? So we're all in the same room. It makes things a little bit easier. There's evidence that there's improved symptom control, quality of life, decreased financial costs to the patient, and often may result in fewer visits to their physicians because it's all coordinated. So both lung treatment programs and lung screening programs really rely on multidisciplinary team meetings, whether they're centralized or decentralized. The patients can certainly have significant advantages, including that they're more likely to receive guideline care, more likely to receive any treatment at all, and decrease the time from diagnosis to treatment. And hopefully it also improves quality of life, and then maybe also palliative care referrals. Multidisciplinary meetings help the clinicians. We all get to discuss complex patients results in improved communication between the members. And I think we feel we're doing a better job if we're all talking in the same room and working for the betterment of the patients. And the community may also benefit in terms of data collection and epidemiologic research and entering patients into clinical trials. And then this is maybe a little bit of a lead in for our next discussion, but multidisciplinary tumor meetings may help reduce the inequalities and the reduce access to treatment for some patients, especially in rural or underserved areas. So, and although there's some disadvantages to multidisciplinary teams, they're few, and hopefully those disadvantages are overshadowed by the significant advantages that seem to be outlined for the multidisciplinary team. So we all enjoy being on a multidisciplinary team. We think we're making a significant difference for the patient, and based on the research here, patients agree with that as well. So thank you very much for listening. I'm happy to take questions. I think we have a break coming up, so I guess we'll do questions here maybe later.
Thank you, Jim, so much. Really valuable information. It's now my pleasure to introduce two speakers to you. And we have Dr. Efren Flores, who is a diagnostic radiologist. He's from Massachusetts General Hospital. And one of his colleagues, Dr. Kelly Irwin, who's a psychiatrist at Massachusetts General Hospital. And they have been working on issues related to some of the inequities that we know exist in lung cancer screening. And they have focused particularly on folks in the mental health community. So we're delighted to hear from Efren and Kelly. Thank you.
Thank you.
Thank you so much for having us today. Let me see, can I share my screen?
It should, is it not showing you the option?
Give me like one participant can share at a time. Multiple parts.
Try one more time, please. Is it still giving you the same error?
Let me see. No, one participant. Let me see, share screen. Okay, got it.
Oh, great. Okay, thank you.
And let me see. Oops, sorry, not this. All right.
It's a great presentation to follow because we're going to talk more about teams. So appreciate the lead in from Dr. Fenton.
Absolutely. So just want to say thank you again for the Dr. Dyer, Dr. Stutz, and everyone in the planning committee meeting for the Colorado Symposium on Lung Cancer Screening. So today, Dr. Irwin or Kelly and myself will be talking about addressing health disparities in lung cancer screening. There are our disclosures. So let's start with disparities in lung cancer outcomes and barriers to lung cancer screening. When we think about lung cancer mortality rates by U.S. county level poverty, in 2021 in general, there are going to be over 200,000 cases of lung cancer screening, lung cancer diagnosed in the U.S. and over 130,000 deaths related to lung cancer mortality. When we look at the graph on their comparing mortality rates among male with poor counties and male from affluent counties, even though over the past few decades, the rates of mortality, the mortality rates have been decreasing, there's a gap between male from poor counties that have a higher mortality rate compared to those from affluent counties. And although we've seen an increase in mortality rates related to lung cancer among women, again, female from or women from poor counties also have a higher mortality rate compared to those from more affluent counties. And when we think about risk factors and primary and secondary prevention related to tobacco use and lung cancer among Black, African American, those we think about the incidence in tobacco use related to socioeconomic factors, smoke exposure, menthol cigarette use, inform about tobacco risks or access to cessation resources. And then when we think about lung cancer, socioeconomic factor, environmental factor that also make this combination more complex. And then the other part is when we think about treatment access and utilization, I mean, again, the provider advised to quit and engagement in behavioral and pharmacological treatment or delayed identification or access to screening are factors that are impacting our patients. So, and all the combination, what it leads to is poor lung cancer outcomes among all our patients. So there are ways that when we think about lung cancer disparity, it's multifactorial. So smoking related factors, societal factor, environmental factor, biology, and access to early detection. But we're going to talk about a little bit more about early detection through lung cancer screening, particularly now that the USPSTF has updated their guidelines to decrease the year and pack year history to be eligible for lung cancer screening.
I'm sorry, I'm trying to figure out where that's coming from. Kelly, maybe mute. I'm not seeing anybody else
I
unmuted.
think it's from Chuck Sneed, who was just muted. So that's where the background voice was coming from.
Okay, all right. Sorry, I was trying to find it. Thank you.
Oh, no
No problem.
worries.
No problem. We'll
I
make it
put
work.
the
Efren and I
microphone
are used to
away.
lots of distractions, and like often it is my children, but it wasn't in this case.
And I'm in the work office, so I no kids running around either, so not a problem. So, but you know, and then when we think about the disparities and how lung cancer screening with the updated guideline can really help us, there's still when we look at the paper from published last year in Cancer and looking at behavioral risk factor surveillance survey data from 2018, so the red states are the ones that participated in this survey, showed that despite having a variability in the eligibility of patients between 10 and 18%, the utilization rates remain low with an average of 10-15%. So there's a lot of work that needs to be done despite the proven benefits on lung cancer screening. And when we think about the multifactorial barriers to lung cancer screening, we can think about lack of awareness, or particularly with the updated guidelines, access challenges among underserved patient population, conducting shared decision-making with decision aids that are at a health literacy level and a language that reflects the community that they're serving, stigma related to smoking and to lung cancer, among others. And more so, instead of when we look at them as a barrier, we think about complex combination of factors, really through the socio-ecological model, when we think about the individual, provider, community, health system level, among other, but more than that, it just really did weights on the patient. So if you think about the patient really want to engage in lung cancer screening, and we think about all the steps that they have to take navigating the healthcare system, and on top of the barriers affecting them, we'll see other factors outside of the individual, including stigma, social stigma, language barriers in the healthcare system, cost concern, and PCP access. You can see why some patients are having difficulty accessing lung cancer screening. But even if they are ready to take the step, even at those challenges or barriers to lung cancer screening present even at the moment of for them to get in. So so that, hold on one second, let me see. So what happened is that when we think about all right, so, so when, I think we're good now. So anyway, so when we're having despite the improved guidelines and considering all the factors outside the system, intentional outreach is needed for lung cancer equity. With the updated guidelines in this graph, every other racial ethnic groups will have increased opportunity, but guidelines alone are not enough for them. And that leads us to the next section with Dr. Irwin.
Thank you so much, Dr. Flores. I appreciate it. You know, we don't often talk about people with mental health disorders as a disparities population. And one of the privileges of collaborating with radiologists is the opportunity to think about how we can team together to raise awareness about this disparity and really take action, because this disparity is modifiable. Next slide. So individuals with serious mental illness, including schizophrenia and bipolar disorder, die 15 to 30 years earlier than the general population. In Massachusetts, that means that a woman without mental illness lives to 82, but a woman with serious mental illness, 52. That's 30 years. Next slide. When we Google Cancer Center and we Google mental health clinic, this is what we see. For the Cancer Center, we see a bright, shiny glass building which we're investing millions and millions of dollars in and talking about on TV, or we see a strip mall. This is the difference in how we invest in cancer and mental health care in the United States and globally. And this impacts challenges that are faced by people affected by mental health disorders. It also means that care is fragmented, uses separate electronic health records, and clinicians are rarely cross-trained in both cancer care and mental health care. Next slide. So Dr. Flores and I wanted to eradicate some common myths. To start with, number one, mental illness is uncommon. No, 1 in 5 individuals in the United States is affected by a mental health disorder. But let's just talk about serious mental illness. So mental health disorders that are really affecting people's functioning affects more than 15 million people in the United States. There are more than 3 million people with schizophrenia, more than 7 million with bipolar disorder. And unfortunately, more than 40% don't have adequate treatment. What do people die with? What's the number one cause of death for people with schizophrenia? If I were to ask you and you guys throw it in the chat, you know, if anybody's brave enough to put what they think is the number one cause of death in the chat, every time I've given this talk, someone thinks that the answer is suicide. But 80% of that mortality gap is due to medical illness. So number one is cardiovascular disease. I appreciate everybody's participation in the chat, love it. Number two is cancer. You know, and also we're learning that people with mental illness have been excluded from 50% of cancer clinical trials. That's completely wrong from a human rights perspective, because with targeted approaches, people can participate in clinical trials. And myth 4, which we'll delve into in a little bit more detail, is that people with mental illness can't quit smoking. They can with targeted approaches. Next slide. So if we think about the cancer care continuum, we think about the different ways in which inequities in cancer care have impacted decreased cancer survival. So people with schizophrenia are more than twice as likely to die from lung cancer. What's driving that? There are lower rates of access to tobacco cessation. Certainly we know less about disparities, but we would hypothesize that there are lower rates of lung cancer screening. There's lower rates of other common screening. People are diagnosed later, they're less likely to get guideline concordant surgery, radiation, chemotherapy, less likely to be referred to clinical trials, less likely to refer to supportive care, more likely to die alone or in a nursing home, and this impacts outcomes. The encouraging thing, I want to leave you guys with some hope, is that early referral to psychiatry or mental health care can improve those outcomes. Next slide. You know, and Dr. Stutz and others have done really wonderful work to think about how we can change our language to decrease the stigma experienced by people affected by lung cancer. We need to extend the same paradigm to the language we use for mental health disorders. This is a word cloud that was taken from interviews done with mental health and oncology clinicians about their experiences working with patients who have been affected by mental illness and cancer. We see some of those words are not super person-centered. You know, when we talk about someone being crazy or psycho or difficult, that's unhelpful, it's not specific, and it engenders both blame and it can be traumatizing for people. So we need to introduce ourselves, ask what people prefer to be called, and use language that we would use in front of the person. Next slide. So I'll give some examples of that just since that's not there. So rather than saying a schizophrenic, say a person affected by schizophrenia. Rather than saying an addict, someone with a tobacco use disorder. So why is this an important population to talk about with lung cancer and lung cancer screening? So 50% of people with schizophrenia smoke. 40% of people affected by bipolar disorder smoke. These are huge amounts of people who are becoming eligible for lung cancer screening as they get older. We also know that people with serious mental illness can safely be prescribed medications to help with tobacco cessation, and they're 5 times more likely to quit when they're connected with both medication and tobacco counseling. Thank you, Jamie, for putting the reference to the guide. It's a wonderful resource. And also we know from our work and from the work of others that the majority of people with serious mental illness are motivated to quit smoking. Next slide. So we looked at this in a sample of people with primarily schizophrenia who are served by a community mental health clinic. We found that among our older patients, more than a third met eligibility for lung cancer screening based on their tobacco history. Yet people rarely believed that they had a high risk of developing lung cancer, and only 1 in 3 reported that their primary care doctors or psychiatrists had assisted with medications for tobacco cessation. So what we have is the potential missed opportunity to engage individuals with schizophrenia, bipolar disorder, and other mental health disorders in tobacco cessation and lung screening. And we thought, how do we meet people where they are? Does it need to be a primary care doctor who's doing shared decision-making? Does that even make the most sense? Might it not make more sense to think about who does this person have established trust with? Who has a skill set where they can tailor shared decision-making to the cognitive needs of the patient? How might we think about where people go and bring that lung cancer screening to them? And that was what motivated Efren and I to develop our collaboration further. Next slide. So that's the idea, right? To meet people where they are. Next slide. So this is our model. This is a model that we've utilized in our trial. It's a randomized trial of a person-centered collaborative care model for people affected by lung cancer, breast cancer, head and neck cancer, and GI cancers who also have a comorbid serious mental illness. And the idea is by using a population-based approach, we can proactively identify people with both serious mental illness and a cancer diagnosis, that we can identify what matters most to the person and the caregiver. And rather than a person and oncologist meeting separately, we can bring in a psychiatrist, bring in their caregiver, and have that team-based approach to care. Proactively address any barriers to care, use evidence-based approaches with the goal of getting them through cancer treatment. So this is part of a randomized trial funded by the National Cancer Institute that helped to inform the way we modified the model for lung screening. Next slide. So here's kind of just a way of thinking about how this can impact the multi-level barriers to cancer equity experienced by people with serious mental illness. So we identify people earlier, given the fragmentation of cancer and mental health care. We can increase trust. We can help to optimize psychiatric symptoms, address social determinants of health. We can foster collaboration between oncology and psychiatry and radiology and primary care, decrease those barriers to communication, and increase continuity across care settings. So this is the thought of like what person-centered collaborative care could be. Next slide. So we talked about whether or not people with serious mental illness can be involved in clinical trials. When I first presented this idea, many people told me that people would not enroll in this trial. We didn't treat people with serious mental illness and they would not consent. But you can see that we recruited people for our pilot trial 3 times faster than goal, that 90% consented, 100% had their assessment, and 88% completed their self-reports. It was also a promising approach to increase access to care. Next slide. So here's a person who participated in our open pilot. She talks about this. I didn't feel wanted. I kept getting pushed around. I had a lump in my neck for 6 months and I could feel them dismissing me. The team listened to me, and that was the difference between life and death. Next slide. So how do we do this better? I think conferences like this are an important first step because we need person-centered bridges across care settings. We need to think pragmatically about what people need and who needs to be in the room to move equity forward. Next slide. I'll turn it over to Dr. Flores.
And this is what it leads us. So listening to Dr. Irwin, I'll just, Kelly, to talking about the patients and the needs and what can we do and how do we collaborate. And it really what inspired me to say, okay, so, there's a lot of opportunity from a radiology standpoint that we can do better and we can contribute. It's just a matter of finding a way to do it rather than can we do it always, like when there's a will, there's a way. So a collaboration to advance equity in lung cancer screening among people with serious mental illness. And what happened is that the usual care model for lung cancer screening is not person-centered care, it's not person-centered. So typically a primary care physician will take care of the person with the mental illness, in the case with people with SMI, and then we'll talk to the radiologist, but then we'll refer the patient there. But typically there's not a direct collaboration. And the reason why we have a dotted line from with mental health clinician is because there's like that fragmentation of mental health from the rest of care, and or at least the usual perception of that. And when we did it, like an adapted model from following Dr. Irwin's work in terms of like team-based approach to screening, where the person is truly at the center. We have primary care, mental health clinicians, and radiologists truly collaborating to advance and facilitate lung cancer screening for patients. So what we did is really more than meeting patients where they are, meeting patients where they need us. So radiologists collaborate with a mental health clinician at PCP in adapting the lung cancer screening education, making sure it reflects the patient population that we're serving. A mental health clinician and a radiologist facilitate the education about lung cancer screening, right? So we're the expert in lung cancer screening, and mental health clinicians are expert in tobacco cessation. So this is the mental health clinic in the community is a prime opportunity to facilitate this, like a teachable moment, because many patients are seeing their mental health provider more frequently than their primary care. So they, in this particular clinic, they were seeing their mental health clinician every month, where they were seeing their primary care maybe once a year or every other year. So what radiologists assist the PCP mental health clinician as streamlining the lung cancer screening process. And what we're doing with is creating a building blocks or a framework that can be adapted to other cancer screening modalities. So you could, eliminate the lung cancer screening and think about screening mammography or other types of care. So in another process, when we did qualitative research, we had an original video showing the lung cancer screening process, and some of the feedback that we received was that the patient was too young compared to the people that will be eligible for lung screening, no information about safely storing belongings. The angle of the video did not show the CT is truly like a donut rather than a tunnel. So people would confuse it with an MRI. And when we got their feedback, multidisciplinary feedback from different stakeholders, then we adapted the video to show this, right? So patient within eligibility age range for lung cancer screening. The video showed that the patient's belongings will be kept secure, which is something very important for people that are experiencing homelessness or those that are experiencing paranoia. And then the angle shows that the patient's entering the donut and the feet coming out, so they know that this is not the loud machine that it looks like a tunnel, like which would be associated with an MRI. But also the educational flyers and that were used as part of the session were adapted to ensure that the language was concise, was repetitive, to ensure this is like the message was clearly delivered for people with difficulty with abstract thinking. Also, the smoking cessation package was focused on overcoming myths related to smoking cessation. And then for the flyer, we focus more on message of hope on the importance of smoking cessation at that moment. And what we did in the prototype of an educational intervention and adapting the educational material through focus group discussion, which recommended person-centered language, and a video demonstrating lung cancer screening, specifically tailored for this patient population. And this intervention, educational intervention, was delivered to lung cancer screening eligible patients with serious mental illness, and pre and post surveys were used to assess for lung cancer risk knowledge and beliefs before and after the intervention. And what we found is that the intervention was feasible and acceptable, with 93% of participants were satisfied with the intervention. And the post-intervention survey shows significantly increased concern about developing lung cancer from the participants, which is something very important because these are patients that have difficulty with abstract thinking. But not only this, we don't want to only focus on lung cancer screening or the intervention. Is the model that we're using and the type of collaboration across discipline is important to advance health equity through lung cancer screening. So when we think about our patients, and when I think about Hispanic patients, a quote from a focal group saying, "How do you ask your doctor about getting a lung screen?" So even if they're interested, they're uncertain. And so our patient needs guide our care. So when we think again about our patient trying to carry like the barrier to care through the social-ecological model, that I feel like it's a burden on the individual patient. And when we think about factor, both upstream factor or in the public health setting or in the social context, and then downstream factor, which are more so the disparities in the health care system factor. And you can see why we need to do more for our patients. So what we were aiming for is truly to creating a health system that empowers patients to take control of their overall health. We talk about bridging care. Dr. Irwin talked about bridging care. And this is like in the framework from the AMA, talking about health equity, including embed equity in every single aspect of the practice, including innovation, push upstream. So not only what we're seeing in the healthcare setting, but also use that to improve what we're seeing more outside the healthcare setting and foster true reconciliation, but more so use that, flip the socio-ecological model so it's not a burden on the patient, but it's more so a system that serves to empower patient more so as an infrastructure to patient to take control of their overall health. So when we think about barriers to care and lung cancer screening, particularly in the model that is published for about Latino community, but can be adapted to other communities, complex barriers require multi-level intervention. So when we're thinking about promoters do lung cancer screening at the awareness, opportunity, and participation, we have to try to develop intervention that address the patient level, at the provider level, and the system level to be more effective, sustainable, and scalable across our system, and truly result in a meaningful change to improve the lives of our patients. So when we think about examples of awareness, we can think about multilingual patient education, or educational that is tailored for specific patient populations, right? So when we have as a system, one size does not fit all. We cannot expect patients to, we'll build it and they'll come. We have to meet them where they need or meet them where they are. So we also, when we think about opportunities, integrating lung cancer screening and screening mammography is another model. People talk about, quote unquote, like opportunistic lung cancer screening. We think about more as a teachable moment. So people are filling out a survey about their breast health. So asking a few more questions that about potentially being eligible for lung cancer screening. And if they're currently smoking, are they interested in quitting, and connecting them with adequate resources, both lung screening and smoking cessation. Was shown in the study that we did. That is a great opportunity, because we had 1,900 responders. Approximately 26% that were of those that were currently smoking requested referrals to cessation, and among those that were eligible, only 30% had undergone lung screening. So there's a lot of work for us to do. And then when we think about participation, we think about other opportunities. So it could be same-day lung screening that we're offering for people getting treated by the Boston Healthcare for the Homeless program. So they're these are a patient population that may have more pressing social issues. So what else can we offer to our patients at the time of their encounter when they're seeing their primary care doctor? So it's up to us as a responsibility to maximize each patient encounter, to rethink how we deliver care, to improve the care for those that need it the most, and really advance health equity in lung cancer screening and lung cancer outcomes, and use this as a model to advance health equity for all patients.
All right, so the road ahead. So Dr. Flores and I hope that this can be a model that will inspire like all kinds of person-centered teams. You know, and first of all, it's also like a lot of fun to work across disciplines. You learn things, and like it really leads to the creativity, which I think keeps us all engaged in care. The next slide. So, you know, with the support of a patient-centered outcomes research engagement award over the past year, we collaborated to think about kind of how do we create more capacity to do this kind of work together? How do we build a community that's able to do person-centered research that matters to the people we're serving? And in particular, how do we do that during the pandemic to prevent widening of the digital divide? We know that not everyone can access patient portals. Not everyone has access to email. I can tell you that only 1 in 10 of the patients I serve access the patient portal. Similarly, 2 in 10 didn't have a consistent phone number. So it's always going to take more than technology. And we are also learning that co-designing those approaches with our stakeholders is a really powerful way to develop solutions that are sustainable and can generate, I think, better health outcomes. And so with that spirit, we built a community of practice. And the domains we focused on are older adults who are more affected by the pandemic, Latino and Latina communities, collaborating with peer specialists, which in the mental health community is sort of similar to navigators, people with a similar experience who can guide people through treatment, people with expertise in serious mental illness and digital technology. So who do we need to bring into the room? So we can add radiologists into there, Efren was there, but also mental health clinicians, peer specialists, people in the community, health disparities researchers, caregivers, advocates, policymakers in the public sector. And what do we want to do better? We want to create a research agenda. We want to think about how we can tailor digital tools to reach the people that need them. We want to think about how we measure the quality of the care we're delivering. How do we increase access to research? How do we adapt consent processes? And how do we measure how good a job we're doing at partnering with community members? Next slide. So I mean, I think a community of practice was a new idea for me, but I liked it, you know, and it's a little bit from like the business school world, but basically it's a group of people who share a passion about something they do, and they get better at it by doing it together. And you need to ask yourself, what do we care about? So all the people in this room care about improving lung cancer screening. Who are we? And what do we do together to advance our shared mission? And then there's a good groundwork, to build a community of practice. I think when we think about how do we build meaningful community partnerships, how do we do meaningful community engaged research, we have a long way to go. As academic institutions, we rarely invest in this kind of collaboration, which takes significant time. As young researchers, often we're told, don't do this work. It's not going to get you what you need. You're not going to get publications. It's going to take too long. You have to be someone who's kind of like, whatever, this is what I want to do to move this work forward, but it shouldn't be that way. Institutions should provide the infrastructure and support needed for long-term partnerships. So a few guidelines that have emerged from our community of practice. First, we need to establish safety and develop a common language. How are we going to talk about mental illness? How are we going to talk about cancer equity? How are we going to talk about smoking? And we need to start with the why. What is our shared purpose? What are the problems that matter? And this is true when we're collaborating clinically too. We need to start by being helpful. How do I be helpful? So for me, often I'm helpful by giving a clinical consultation or a referral. And that's a great way to start to build a strong partnership. And how do we build teams that can be creative and persistent together? One way is through coalition building. We need to be transparent about what we can and can't do and evaluate how well it's working along the way. We need to start by thinking about sustainability from the beginning. Next slide. So this is our coalition, the Engage Initiative, which is a group of people who share a commitment that mental illness should never be a barrier to cancer care or palliative care. Some pictures of the people who are part of that coalition. I certainly invite you all to join it. And as Arundhati Roy says, there's really no such thing as the voiceless. There are only the deliberately silenced or the preferably unheard. Next slide. So I encourage you to take the pledge with us. I pledge to ensure that mental illness is never a barrier to cancer care. You can do that on our website or just, yourself. And I know that Dr. Stutz has a similar pledge around lung cancer screening equity. So I encourage you to join the coalition or start a coalition that's related to what you care most about with equity and lung cancer screening, and to encourage you to ask questions to Dr. Flores and me about how to do that. Thank you very much for having us.
With that, I just want to say thank you for the opportunity to be here. More so, this is really an example. The reason why we wanted to do it together, because what better way to showcase the partnerships that are needed to advance this work than doing something together, right? So where we bring all our expertise or like our subject matter expert, like Dr. Irwin in psychiatry, and me coming from radiology, and then coming together for a shared purpose of advancing health equity for underserved patient population, where it could be individual with severe mental illness or other underserved or vulnerable patient populations. And with that, I just want to say thank you again to the Colorado Symposium, everybody in the organization for this. And please feel free, any questions or anything, anytime.
Thank you so much. What a compelling presentation. I just admire the work you've done, and you are just a great example for all of us on this important team approach and really addressing so many patients that I think have been left out. So we really, really appreciate all that you've offered today. We are moving on to a break, but I imagine there may be some questions. And if you could stay with us for just a few more minutes, we can look at the chat and see if questions come through. And if questions come through later, we'll let you know. But it's just a real privilege to hear from you both today. And it is so much appreciated by all of us out here in Colorado.
I wish we could be in Colorado hanging out. But
Next time we'll be
Next time we'll have you in person.
Yeah.
We'll do a rain check.
All right.
That's right.
Thank
I'm happy to hang out
you.
for 5 minutes if there's questions that come up.
Okay.
So I'll just stay.
All right. So Christy, can you keep up our video for just a few minutes?
Yep. Yeah.
Okay. Thanks so very much.
Dr. Irwin and Dr. Flores, just magical presentation that really highlights the targeted community that you're thinking about. But I love the model of for applying health equity on a broader level to other communities. And we'll talk a little bit about later on this afternoon about our work in rural. But one of the points I wanted to really emphasize or ask you about was the missed care opportunities framework that you mentioned, because I just sort of realized that no-show is a laden, value-laden terminology. Now, I really care about, that missed care opportunities because adherence is so vitally important to the lung cancer screening context. But yet, coming back to the idea that words matter, how do we message that with our candidates and participants in our program to make sure that we're not being condescending in our efforts to support adherence?
I mean, I can start with that in terms of like, when we were thinking about missed care opportunities, right? So instead of referring to like to missed appointments and or no shows, and it, really, I always go back to like one of the patients that she was scheduled for like a thoracic imaging study, missed a couple of appointments, and then on the third time, the patient came this time, and I went in to talk to the patient in the room just to say, so as radiology, I just wanted to like see if there are additional symptoms or something that would provide me more clinical information to provide a better diagnostic report. And I was just shocked because first the patient was Spanish speaking, and then she was telling me, "Oh, I missed the other. I feel okay. Nothing has changed. I missed the other appointment because I could not understand the reminder message, which was in English." And the third time she asked a neighbor to translate it for her. So that really made me think of how many more patients where we're like mislabeled, right? So, or like when we think it's like no show, but actually the patient really wants to engage in their care, just that they don't truly have an opportunity. Like our system does not reflect, and it's such an easy, in that to me, it would be like an easy lift, right? So sending them a reminder message in a language that they can understand, but many more opportunities that patients don't have a chance where we have only offer appointment from 8 to 5 and people are working 2 jobs, right? So, and when putting food on the table or getting a screening test for an asymptomatic disease and you only have limited hours and you have to decide where I put food on the table or pay this month's rent or get my lung screening or screening mammo for something that I may or may not have, then you're gonna deal with the more pressing need. And so I can, from that perspective, it's the way that for us to change our language, it starts with compassion and empathy, right? So we can't do equity work or advance equity meaningfully. We don't infuse empathy in every aspect of the care, from revamping our medical education because we're like thinking about stereotypes and that's how we approach care, but also really in our language, right? So we don't talk about smokers anymore. We talk about people who currently smoke or formerly smoked, right? So and then, or a big, and then same thing with people with SMI. We don't allow medical conditions to define the individual. Is a person with diabetes or person with hypertension or person with schizophrenia, not schizophrenic or diabetic. That's I'll let Kelly chip in a little bit more.
Yeah, I have a few things to say about that. No, so I think that the challenging thing is that the language of crazy and psycho and manic or that's OCD, it's so pervasive. And in the language, it's not only used commonly in the press, but also in medical meetings. You know, one day I counted the amount of times that happened in the course of a day, 6 times, 6 meetings. And because mental health disorders are not something that people always know who's affected by, it's something that people don't always choose to disclose. We don't know who's in the room, and not that that should be the driver, but it's something that's important to know. There are people in the room, always. It's common enough that like there's always going to be someone in the room that's affected by a mental health disorder. And we really need to speak from that framework. When we think about the many times people have been discriminated against, the many patients who have told me, I went in with chest pain and people told me it was just me using drugs. Get the hell out of the office, get the hell out of the, they didn't take me seriously. There wasn't time to talk about cancer screening. I was scared about it. I didn't know if I should do it. I didn't know what it meant, and people didn't necessarily have the time to have the conversation and really listen. And so having a trauma-informed framework where we establish safety first and take the time to use the language that people resonate with. I think that there's oftentimes more time in the office of the person they trust the most. So sometimes that's someone in the community health center, but sometimes it's someone who's a mental health clinician. For what it's worth, mental health clinicians also need to work in their language. It is not something that is exclusive to radiologists. I need to work in my language, and we only do that together by asking. And when in doubt, just ask people what they want to be called. That's a really good way to start. People also tell me the thing that matters the most to them is they really appreciate when physicians introduce themselves as like, hi, I'm Kelly Irwin, as opposed to I'm Dr. Irwin, and it puts people on equal ground. Not everybody's the same, but that's something that many people have mentioned to me is a wonderful way to start an encounter.
Wow, thank you so much. You guys have such a wonderful and sensitive approach to these issues, and it's just it's fabulous. Thank you. We just are delighted to be able to have you with us and share your thoughts with us today. And you're welcome to stay if you'd like. We are going to move on in our presentation. We are so fortunate in Colorado that we have some real national leaders in some research projects going on in lung cancer screening. And so I wanted to introduce you to our first speaker under our unique lung cancer screening initiative section, Dr. Deborah Ritzwaller. She is a researcher with Kaiser, Colorado. She's a senior investigator, and she's going to be describing to us all today some work that she's been doing with the Prosper Project. Deb.
Oh, thanks so much. So thanks for the introduction, and thank you both to Debbie and the organizers for inviting us to this. This has just been a fabulous presentation, and this speakers have just been, so enlightening and so important to this particular topic. But I have to say, very much in contrast, especially to the last very important discussion, I'm going to flip to much more of a data-oriented overview. So and I'm going to set my timer. So on that note, I'm going to discuss today the NCI-sponsored initiative called Population-Based Research to Optimize the Screening Process, Prosper as it is known, and specifically the Lung Cancer Screening Research Center, Prosper Lung, here today. So Prosper is a consortium, an NCI-sponsored consortium that consists of screening centers that address 3 organ-specific types, specifically colorectal, cervical, and lung. And colorectal and cervical already had their acronyms going with PRECISE and METRICS. So we added ours, which is known as LOTUS, Lung Cancer Screening Optimization in the US. So from here forward, I'm going to refer to it as LOTUS. So, I also want to say up front that I have no conflicts with respect to the content of this presentation, and also my colleagues from Kaiser are in the background ready to answer any questions or issues that come up in the chat. So again, today, a bit more data-oriented, quick overview of what LOTUS is, and then some updates on key findings, recent analyses, and publications related to the lung cancer screening processes that we are evaluating. So funded by NCI in 2018, LOTUS is a multi-site research center. We're studying the implementation and delivery of lung cancer screening and associated outcomes, also with a particular focus on disparities in screening and outcomes, particularly on the disparities in lung cancer mortality across various demographics, age, sex, race, ethnicity, etc. And we are capturing multi-level factors, including patient, provider, facility, system, community, and census tract measures of social economic status or social determinants of health, but again, census tract measures. Kaiser, Colorado is the lead site. Both the administrative and data cores are staffed and located here in Colorado. And again, back to the disparities focus, LOTUS is comprised of 5 heterogeneous US healthcare delivery systems located in communities, diverse communities across, as noted on the map here. And I'm really glad that both Kyla and Jim described characteristics associated with centralized versus decentralized lung cancer screening programs, because this issue is key to many of our findings. So back to the diverse sites. Marshfield Clinic is a non-integrated system serving rural and low SES patients in central and northern Wisconsin, has a decentralized lung cancer screening program. Henry Ford is a mixed model of integrated and non-integrated care delivery providers, including safety net centers, serving a population that's 30% Black African American. Decentralized program initially, but then implemented a centralized program consistent with many of the characteristics we heard about previously. University of Pennsylvania is an academic, and Penn Medicine is an academic referral center with diverse distributed primary and specialty care clinics across the Philadelphia area. And we have added the data is not shown today, but a rural center in Lancaster. Here at Kaiser, Colorado, 60% of our membership less than 65 are enrolled in high deductible plans, and 16% of our membership, consistent with our underlying population in the Denver metro area, self-identify as Hispanic. And we do have a centralized program, as Kyla described. And at Kaiser Permanente Hawaii, also a centralized program. Cancer screening is extraordinarily understudied in Native Hawaiians and Pacific Islanders, the same population that has higher incidence. So a lot of data here, so my apologies for going fast and lots of graphics. But while not presented here, the characteristics of our underlying LOTUS population of approximately 2 million individuals aged 35 to 89 differ from those of the more than 18,000 who have received a screen through to September 2019. And while in contrast to BRFS and other BRFSS and other studies that have been discussed previously, we've not yet run comparison to other screening eligible cohorts. But we want to emphasize that the LOTUS population, and this was a surprise after we started collecting data, are 100% insured individuals, across all spectrums of payers, self-pay, Medicaid, Medicare, et cetera, but they're insured individuals who are engaged in high quality healthcare systems. So I think I want to just make sure we keep this in mind when we compare to other studies and other publications. However, when we look at the screening population, we can see the demographic characteristics, and especially in the upper right-hand box, we see the variation by, I'm sorry, this was sitting in the shared part. Characteristics by screened versus non-screened versus the screened eligible. And the comorbidity or the morbidity burden is quite different. And similarly, when we compare specific diagnosis codes compared to the NLST, we see again that the comorbidity burden in our community-based setting differs from the NLST and higher for many of those characteristics, many of those diagnoses consistent with individuals with a significant smoking history. So this is the number of screens that we've captured through 2019, more than 18,000 individuals with over 30,000 baseline and annual screens, and excuse me, an additional 8,500 interval scans. So those CTs that are diagnostic scans, excuse me, done after a positive screen for those noted with a lung RADS 3 or 4, as described by Debbie and others. This is Kaiser Colorado specific information through July of this year. Again, at 7,000 members, 17,000 screens, et cetera. And we're seeing this great dip with the emergence of the pandemic in early 2020. And to take a closer look at that, and consistent with many publications, including one that reviewed the Prosper sites, we saw more than a 90% drop in lung cancer screens. We're rebounding, but we're still seeing a reduction in the number or proportion of new baseline scans and follow-up for that matter. We're still investigating some of that. But this slide shows the proportion of approximately 35,000 individuals within the LOTUS cohort that have documented within the EHR smoking eligibility. So if we apply the eligibility criteria to only those who are current and former smokers for the same age eligible cohort, it approaches 300,000. So again, ascertainment of eligibility is a problem. But looking at just those who are eligible, our screening rates for Kaiser, Colorado are quite high. And this is consistent with, I believe, what we're seeing for the same time period in the civic data. So again, Kaiser making up the largest proportion, I believe, in both cohorts. This describes the proportion of the eligible cohort by any screen. So we're looking at some variation by age and by race ethnicity. I want to caveat this, a couple of these lines here. I think the Hispanic rate may reflect the high screening participation within the Colorado site relative to the other 4 data participating sites. And back to the updates to the USPSTF guidelines. So we took a close look on what those changes meant with respect to our LOTUS cohort. And as we describe in a recently published JAMA Open Network paper, we find that the LOTUS population with complete smoking history is projected to increase by 53%. Contrast to some other microsimulation models that inform these updated recommendations. I think they proposed upwards of 80, 85, or 87%. Within the Colorado population would increase by 50%, and a larger relative increase in newly eligible individuals who self-identify as Asian, Native Hawaiian, Pacific Islander, Hispanic, or non-Hispanic Black, with the largest differential noted here. And I know there's been some conflicting back and forth in some publications about what does this mean if younger, more diverse individuals are eligible, but those are still most likely are still the same individuals who may be more likely to have less access or be insured. So we're going to watch closely in our data what this means, and especially relative to other publications from BRFSS and other survey-based measures. Again, larger relatively increase in women, and a larger proportion of individuals in lower SES census tract areas. And when we applied the USPSTF 21 expansion criteria to our existing cancer registry data, we saw an increase in the identification of incident lung cancers by 30%. So this means that an additional 30% would have been eligible for screens. We also looked at the stage, age, and other characteristics. So that's an important measure as well. Could we have caught some of these folks at an earlier stage via screening? But back to the issue of if it's ordered, do you follow through? I thought that was, spot on with what we're seeing here in the LOTUS data. Digging deeper into the screening processes, we found that 40% of those who receive a provider order of referral for LCS, LCS LOTUS CT, do not go through with the screening exam. We've got a lot of analyses underway on this particular topic, slicing and dicing the data, but at the initial cut, and this was presented as an ASCO abstract last summer or last spring, we found that males and former smokers and those with higher morbidity burden and those engaged with a centralized lung cancer screening program were more likely to complete a screen after receiving an order. So again, this is a really an important and consistent finding. In a recent publication by Andrea Burnett Hartman in the Annals of the American Thoracic Society, we also took a look at the assignment of lung RADs across our cohort, and we found the assignment of these of lung RADs varied by site, and the associate. And we also took a look at what were the factors associated with being assigned a positive scan. Again, a lung RADS 3 or 4. As noted here, we see age and COPD. A diagnosis of COPD is positively associated with the assignment of a lung RADS 3 or 4, but this quite interesting, I don't know if unique or not, but finding that those with a noted BMI, and this is out of the EHR, BMI of 30 or higher, they're less likely to be assigned an LRADS 3 or 4. And I know there's some other work going on by Rebecca Smith-Byman and others who are looking at dose by weight, et cetera. So we don't think it's explained by poor quality imaging, but again, something to explore further. We also took a look, and I think this is consistent with Aaron's and other work with the civic data. We're looking more specifically into adherence to LUNGRAD's recommendation after the baseline screen. And we're finding that only 57% of the adults receiving a lung cancer screening were compliant or were adherent with the recommendations. And again, we're seeing higher adherence at centralized programs and older former smokers and those with a higher median income were associated with increased adherence. This was presented at ASCO, and it's current, and a follow-up paper is under review right now. So back to Colorado, a key outcome that both leadership, policymakers, public health, all of us are most interested in. What is the impact of lung cancer screening on outcomes like stage at diagnosis? Recall that stage matters with respect to survival. Are we seeing a hint? Are we making a dent yet? And we're seeing that the proportion of incident cancers that are screen detected, they have been increasing similarly with the uptake of participation in screening here in Colorado. And we are getting the first hint, and I think there's a JAMA Onc, I can't remember, a JCO paper, I think it was out today using SEER data. It's also finding some similar statistics that we are starting to see a hint. We see a downward trend that I believe has been in our 5-side analysis, has been shown to be statistically significant, and an uptick of early stage. So that, of course, is starting to shift a bit again with the pandemic shutdowns and reductions in screening. So I think I'll stop there. I think I'm about out of time, but just in conclusion, we've assembled a really large screening cohort with lots and lots of diverse data from diverse community-based settings. And in some, we've observed variation in uptake of lung cancer screening, variation in the assignment of LUNGRADs, and variation into the adherence and follow-up. We're also observing a bit of hints of a shift in stage, but we've got a long ways to go. We're in looking at multi-level analyses of many of these issues that we hope will help illuminate some of the factors and help us disentangle or better understand what these mean, especially when we look at different populations, whether it's by some measures of SES or race or ethnicity, et cetera. And our current effort is associated right now, a very heavy lift with collecting data through 2021 that will allow us additional evaluations regarding the impact of the COVID pandemic, including capture of the telehealth events associated with the shift of care. So I will stop there. Many thanks to a very big, I think this represents probably half the center team across all these centers, but many thanks to those who really did the work to put these analyses and these data together. So thank you again for the invitation. This has just been a great symposium.
Thank you, Deb. Thank you so much. It is now my pleasure. There's some sort of feedback that's weird. Just wonderful data, Deb. Thank you so much. It's now my pleasure to introduce Dr. Robert Keith. And Dr. Keith is a pulmonologist with the Denver VA and a professor of medicine with the University of Colorado. And he's going to share with us what's going on with lung cancer screening at the VA. Thank you, Bob.
Great. Thank you so much to everyone. As usual at these symposia, I bring a little and I learn a ton. So I've learned a ton so far with the talks already. And I'd like to introduce you all to a program that some of you may know about and some of you may not. Let me just get all my settings going here. That the VA launched about a year ago. I don't think I have to convince you that veterans smoke at higher rates than the general population. I think we also have the same economic and rural versus urban disparities among the population we care for. In fact, the VA calls it rural or even frontier locations. Like the US, it's the #1 cause of cancer mortality in the VA. In fact, it's about 30% of all cancer deaths are lung cancer. And there are over 8,000 cases a year. Majority present with advanced stage disease, even higher rates than in the general population. The right side of this slide just shows some education the VA has put out. The other thing I think about with the vets that we care for, they also have unique exposures that may be related to their military experience, right? So I take care of patients who worked in the naval shipyards and have asbestos exposure. I take care of patients who had burn pit exposure in Desert Storm and some of the more recent conflicts in the Middle East. So layered on top of the smoking, which is you can't ignore, are other potential risk factors among this population. So the VA has started to take this very seriously. Other information, and people haven't come in much on this today, but if you ask yourself, how good of a job are we doing at screening? I think we all might agree that we're doing a fairly poor job. So this just looks at lung cancer screening within the VA. I can tell you most of the patients we take care of are not doctor shopping. You know, they may end up in other facilities for more emergency or acute care, but they do receive and want to receive their care through the VA. But this just looks, it's a kind of a heat map across the US. And the heat is very low in our region. In fact, if you look down, and this is data that's done before our program started, you know, we are not screening very well of the patients who should be screened. So the VA looked at this and said, we need to start a more centralized program and roll it out across the country. So we don't have cool acronyms like PROSPER and LOTUS. We have VA acronyms like LPOP. And what LPOP stands for is Lung Precision Oncology, with really 2 areas of focus. The first is cancer screening, and the second is diagnosis and treatment, with the belief that where you live shouldn't affect how you're diagnosed or how you're screened or how you're treated. And so we put together a consortium, you know, the kind of the classic hub and spoke model that was funded just about a year ago. We got the good news. And here's our consortium. We are a healthcare system. So we're the VA Eastern Colorado Healthcare System based here in Aurora. Our spoke sites are the Western Colorado System in Grand Junction, Cheyenne VA Medical Center, Sheridan VA Medical Center, and then Fort Harrison, Montana, which is in Helena, is also part of our system. So you can see a very broad geographic area of the US. At the same time, the VA funded sites across the country. So I don't know who drew these maps, but this is how the VA dices the US into different what are called VISNs, or Veterans Integrated Service Networks. So of course, the Northeast gets to be #1, and the numbers get larger as you head west. We're in VISN 19, and we actually also includes Oklahoma, but this is how they dice it up, and you can see that there are centers geographically across the country, and even to including areas that are beyond the lower 48. And really what they've done is they've wanted to sort of implement science, precision medicine, and a learning healthcare system. And I think one of the takeaways today has been, we all want to do this, and then when you start to do it, it becomes incredibly complicated, and it really is, you know, team science and team implementation. So this is just a graphic to say that, you know, precision medicine is great, but if we can't apply it to our populations, are we really serving them well? So how do we implement the science, and how do we think of our healthcare system as sort of a learning entity? So in the screening world, the VA put together a lung cancer screening platform. So another acronym, LCSP. This is a web-based that was originally developed at a couple of VA medical centers across the country, Portland, San Francisco, Minneapolis. It's now managed centrally. We implement clinical reminders. So the VA uses something called a PACT model. And I think we saw that was referred to by Doctors Flores and Irwin, thinking about, PACT stands for Patient Aligned Care Team. And so the patient's at the center. So when someone checks in for their clinic visit, the nurse who checks them in can check age, can do tobacco history. We struggle mightily at pulling out tobacco history from the VA medical record. And are they current or former? And then that person can be flagged as somebody who should have lung cancer screening considered by their PCP. It also helps to make sure patients get proper follow-up. I think, if you think that the screening data looks bad, look at the adherence data. And that's a real challenge. I think when we centralize this, we can look at view from multiple sites. So within our network, or our LPOP network here in VISN 19, all the CAT scans that are done at Sheridan, Wyoming at the VA are read in Denver. So there are ways to kind of integrate this. And I think, we've learned a lot during COVID with virtual care and telephone care, and screening is one of those things that fits real well. The other thing that it is an incredible need that we get a lot of referrals for is, what about incidentally detected nodules? So those, you come in the ER, they think you have a PE, you get a CT angio, you don't have a PE, but you have a nodule. And so how are these patients followed? And since they weren't detected in a screening setting, do we need a separate way to manage them? And so we're working on sort of a parallel management program. And last but not least, the holy grail for many of us who work at the VA is that the VA will mandate lung cancer screening. So for a long time, they recommended it. They said, if your patient asks you for it, you should do it. And, not many of my patients ask me for a colonoscopy or a PSA or a lung CT. So I think, some of this has got to be trickled down from above to say, look, we should do this. This is a huge problem. In a nod to our radiology colleagues, Debbie, the VA does use lung rads, but what we've had to do within the VA system is they've assigned these national diagnostic codes that correlate. I don't have all the lung rads categories here, but there's a national diagnostic code that correlates to the lung rad categories. And with much work with our radiology group here, you now can't sign your low-dose CT report until you put a national diagnostic code down. But what that allows is a nodule management dashboard to then go in and pull out these results and then manage who needs a follow-up scan. Was there another finding, et cetera, et cetera. So this has been critical for our group. But if you're going to big program, you got to prove that it works, right? So there are performance metrics. They can, somebody at central office can look at our network and say, you have X number of patients who are in this age group. We think your smoking rates or current or former smoking rates are this. How many people are eligible or actually getting screened? I think we also have to think of screening in the context of good treatment and diagnostics. So they really want us to look at the molecular testing that will drive treatment. And then ultimately, this is going to be a great way for us to do biomarker and other treatment trials to a large network of sites. I think we'll be able to address a lot of healthcare disparities, but the only one we can't address is there's still a very large gender bias within the VA. But of currently deployed military, 50% are female. So that is going to pivot over time. And just an example, I think Deborah on the last talk gave one of these. So this is Minneapolis that developed this lung cancer screening tool. They implemented it early, and what you can see is when they started to screen, just what you would hope for. We're going to see more stage 1s and we're going to see fewer stage 4s. And that's exactly what happened. So that's what's happening at the VA. They've got some milestones. It's incredibly that's a ton of work, and I'm super thankful to our to our, we have a nodule navigator. We don't have as many people as National Zero, so I'm kind of jealous, Jim, but we are building a program of people and really thinking about what can we unload from the PCPs and what can we, have them help us with. So this sort of looks at programmatic milestones. We're hiring the staff, which is no small feat here. We're starting to get this rolled out at some of our hub and spoke sites. And then we're transitioning more to, we will in the future transition to more of a sustainability module, because as the program grows, you can imagine one nodule navigator can maybe manage 1,000 to 1,500 patients. And when you get beyond that, you have to go request support for a second person to help. And then lastly, or second to last, my second to last slide, there is this oncology lung pathway. And so this ties into making sure that we're doing the correct molecular testing on our patients. And, lung cancer is the poster child of precision medicine. So when you have a diagnosis, are you looking for genetic mutations? Are you looking for, markers that would predict response to immunotherapy, et cetera? And if you're not, then tell us why you're not, right? Some patients choose, they don't want chemotherapy. All they want is radiation, or they don't want any treatment. But tell us so we can learn how to make this as patient-centered as possible. And then this is my last slide. Again, within the VA, it's the largest healthcare provider. We're here the day after Veterans Day, and really they're trying to leverage the medical record that's present to use this both to look at, are there clinical pathways that can help us? Are there programs, we're part of this National Precision Oncology Program. And then within that, they've really focused on lung oncology. This is now GU oncology, and then also, the female veterans and women's oncology. So with that, I will stop.
Thank you so much, Bob. It's it's wonderful to hear about all this good work then going on at the VA. And we really want to do anything we can to help support all of your efforts. So thank you.
Thank you.
We're going to move on now to Dr. Jamie Stutz, and he's going to be discussing with us some research work that he's been doing at the university on supporting lung cancer screening implementation in rural primary care. Thank you, Jamie.
Thanks, Deb. It's just an honor to be able to present some of this work and to follow some of the amazing presentations. The work that Dr. Keith is doing in the VA, to our colleagues in Boston and the work that they're doing, just really exciting things, let alone the scope of the work that Dr. Ritzwaller brings in perspectives on lung cancer screening to really create Colorado as a hub of lung cancer screening research and practice. So just to let you know that the two of our future speakers are here in this picture associated with the White Ribbon Project, and we're really happy to have them on board. So Pierre and Heidi, and then Bonnie and Joe, look forward to hearing what you have to say in a few minutes. I have a few conflicts that I want to address just right up front with working with the J&J Lung Cancer Initiative and the Lung Ambition Alliance, and I also serve as go-to and have funding from NCI. Really, when I think of implementing lung cancer screening, I think we have two twin challenges that have to be tackled together. And one is bringing up our levels of uptake and making sure people have access to that, but also to do it in a person-centered and community-engaged manner so that we can achieve the adherence that is really going to drive the outcomes. So uptake is necessary, but not sufficient to really have the kind of impact that we want to have in lung cancer screening. So I'm going to tell you about a few projects that we have here at the University of Colorado and throughout Colorado to actually leverage this amazing tool we have in lung cancer screening. The first one is the Implementation Science Center led by Dr. Russ Glasgow and as well as Kathy Bradley. And here, these centers are really challenged or tasked with helping implement some of our evidence-based strategies that we have. To talk about exactly what Bob was mentioning is like, it's not enough to know this stuff. It's only valuable when we deliver it to people. And that is really the challenge of implementation science, to making sure our best science gets to our community. And the Implementation Science Center here in Colorado focuses on pragmatic approaches to cancer prevention control in rural primary care, partnering with rural care centers to help them integrate lung cancer screening more effectively is actually the first task. And so our initial focus with this P50 center, or with this Implementation Science Center from the National Cancer Institute, is to help our rural clinicians embrace low-dose CTs using both shared decision-making and evidence-based tobacco treatment in a compassionate and empathic manner. So with this Colorado Implementation Science Center, I'm going to talk about 3 different projects. One that facilitates the implementation of lung cancer screening in rural primary care. Then looking at attitudes toward engagement among individuals who are practicing clinicians in rural settings. And then we're also some work that we're doing to develop strategies to reach primary care in rural areas as well. And finally, I'll close up with a project that we have called Project ACTS, which is designed to facilitate person-centered and community-engaged lung cancer screening in rural Colorado and throughout the country. So this first project is led by Dr. Dan Matlock and is aimed at conducting a feasibility trial of person-centered lung cancer screening strategies in Colorado primary care clinics in our rural areas. We've developed this new decision aid that you can see the first page of here to be very person-centered and very, very brief. As Dr. Crofta mentioned, this discussion does not have to be extensive. It does not have to be a 20-minute consultation. It can be just a couple minutes to talk about the highlights of lung cancer screening. And if a person decides to buy into that, then we can move on and get them enrolled and get going. Some may have questions. In that case, it might take a few minutes longer in the consultation. But this decision aid is a structured process to making sure that people have the information that they need to not only commit to going that first time for a low-dose CT, but understanding that it is a process of lung cancer screening and to sustain that engagement throughout over the years. With this project, we're using a study design where we'll kind of roll things out in 4 to 6 rural primary care clinics and assess them. But one of the key things that Dr. Ritzwaller is also involved in this project is doing some mapping of the processes as well as the costs associated with implementing lung cancer screening, so that we can try to identify the ways that rural primary care clinics can optimize the delivery without creating extensive burden. We also, along with this, created some continuing education programs where we do in a community engaged manner. We present these and work with the primary care clinics to, put the information we have in context. Then we allow them to access to, here's the second page of the decision aid, I snuck that in there, to implement the lung cancer decision aid and other interventions that we have there. We also give them access to more educational materials that they can do online. And then we once again go back and look at how their processes and procedures may have changed over time. We are still right here at this early phase on this particular project, and we're just moving toward the point of implementing this work in the clinics. So one of the things that I tend to think about and believe that's at least partially relevant is the analogy of the blind men and the elephant in terms of what you see in terms of the lung cancer screening landscape. And here, I'm sorry, Dr. Crofta, but I tend to think that the primary care team and primary care clinicians tend to see more of the business end of lung cancer screening in terms of the difficulty of initiating it, getting it going, and managing nodules, and really taking a lot of responsibility for the starting of the process. Whereas our cardiothoracic surgery colleagues see sort of the end of it where they get to have the maximal benefit in terms of the side of lung cancer screening. And part of that, the reason I highlight this is because we really fail to understand and empathize with our primary care clinician colleagues at just how complex it is to add another evidence-based practice onto their already extremely substantial burden of care. And so we believe that we can do a better job of engaging with our primary care clinicians if we simply ask them to give us their insights. Instead of just expecting them to follow the orders of the U.S. Preventive Services Task Force because this is effective, we want to understand how can we help and partner with the clinicians to engage them effectively and build their commitment to integrating lung cancer screening into their routine practices, and then designing our outreach efforts and our engagement efforts to match with those preferences across different clinicians and across different settings. And we may need different approaches to do that in a way to really optimize and help them integrate. And so we have been working on partnering with primary care clinicians to learn about their experience with lung cancer screening. And then we're going to do some surveying after that to really design interventions that bring this hopefully to a higher level of on their radar and help them understand just how vitally important it is, but also work with them to build the systems to really optimize care. And we've talked about a theme for today has been lung cancer screening is a team sport. And part of that, a big part of that is primary care. And we need to honor and respect their skills and expertise that they bring to the table with the relationships they have with their patients in order to really sustain this long term. In terms of looking at the community members themselves, we went to the Rural Cancer Advisory Board that's led by Dr. Hilary Lum. It's also associated with the Implementation Science Center to really understand what rural community members understand about lung cancer screening and to gauge their awareness and identify what their concerns are and help them inform processes that we can help really partner and then message correctly, send the right images, and also design intervention approaches that will align with rural perspectives. When we did that, you can see the two things that are highlighted in terms of the valuable takeaway points are that collaboration with local clinicians and trusted local health departments is absolutely vital. That local challenges need local solutions and they need local trusted individuals to be the leveraging points. We also want to foster the relationships with these rural clinicians and healthcare systems to establish trustworthiness and to bring the lung cancer screening message as an opportunity, not a hassle, in terms of bringing, improving population health in rural areas. The last thing I will want to mention is that what we're doing with the engaged approach to lung cancer screening in working with both primary care clinicians and lung cancer screening programs to help them overcome some of the substantial barriers to facilitating program adherence. Both Dr. Ritzwaller and Dr. Keith mentioned some of the challenges with adherence, and I won't go into just how critically important adherence is to actually benefiting from lung cancer screening. I hope you'll just accept that argument and based on some of the things that Aaron Hirsch presented last Friday. But most of the time, our efforts to build adherence have utilized very expensive software that not all rural programs can afford. Matter of fact, very few can afford. And they also don't have identified impact. We think that they work. There's some observational data to suggest that they do, but we have a long way to go. So we designed Project ACTS, which led to the forming of what we call the engaged approach to lung cancer screening. And we're just starting to work with 4 sites here in Colorado. We're looking for sites actually, and then 4 sites across the country to do this process. We're doing a randomized feasibility trial to see how our engaged approach can compare against usual care on outcomes related to adherence. And we believe, consistent with what we were talking about before and what Dr. Ritzwaller mentioned, that there are actually 3 elements of adherence to lung cancer screening. And so we developed this tripartite model that focuses on the fact that just because a referral takes place does not mean that there's actually going to be uptake. And Dr. Ritzwaller highlighted the fact that there's a large percentage of individuals that do not make this first bridge from referral to uptake. This has very important influences on just program efficiency. But if people can't make this bridge, there's no way to benefit from lung cancer screening. Similarly, we have to help on these next two outcomes where uptake sometimes leads to suspicious nodules and requires an interval scanning, as well as the very important piece of the puzzle of the annual screens that need to occur. The important thing about differentiating these three elements of adherence is that the factors that influence each of these may be dramatically different, and we may need different interventions to support the transition to helping people come back for an interval scan where they're being followed for a nodule or some other concern versus those folks that have a lung RADS 1 or 2, so essentially a clear scan, and are only recommended to come back on an annual basis. And so what we've done to address those is the engaged approach is a very person-centered to try to put that individual at the center of the process and build institutional resources around that to help support their engagement. And I won't go through all of these, but these are just some of the couple of the key elements of person-centered care, emphasizing the relationship that lung cancer screening is a high touch, high relationship building to build that trust. This community has no reason to trust us. We've not been all that kind to this eligible community based on how we've managed tobacco treatment efforts in the past. And we want to really try to help them create a community of trust so that they can continue to return and benefit from the screening programs that we have to offer. To support that, we built participant-facing tools in terms of completely redesigning the letters that are communicated between the program and the participants, as well as the referring clinicians, to help encourage the use of newsletters, to help people build comfort with the screening program and trust in between scans, and as well as making it very explicit what the expectations are to the guides to do the simple stuff like where to park, how to get into the scanner, and these types of things. We also help with some training elements for the staff, recognizing that every single person that interacts with a screening program candidate has a chance to build engagement and provide support and encouragement and reduce their stress, and understanding that, and by doing some trainings and providing some other materials, as well as trying to create a community among lung cancer screening programs like we're doing here with the screening symposium, so that we can share best practices and have a community that's committed to optimal results. So I'll close up here with talking a little bit about, the entire lung cancer screening landscape. And I know Dr. Fenton talked a little bit about this probably last week, but we're not doing that great in terms of the eligible community. This little yellowish brown bar there is where we are in terms of the percentage of individuals in Colorado who are eligible for lung cancer screening and have received a lung cancer screening. And this data from 2020 and 2019. And so you can see that the vast majority of states are doing better than we are. We're kind of in the lower third tier, and we've got a lot of room for improvement. Now, I don't mention this to be, I only mention this because this is what's possible. When you put individuals at the center of the process, and when you build extensive community engagement, you can achieve, even with a tobacco burden state that has the highest incidence and mortality from lung cancer, that you can achieve implementation of lung cancer screening in Kentucky here that's almost reaching 20%. That's still horrible in the grand scheme of things, but it's a trajectory, and we're moving there. And along the same lines with what Dr. Keith was presenting, this is perhaps my most exciting slide. This is data regarding late stage diagnosis in Kentucky. You can see from the years 2009 to 2014, we were at 81%. That in itself is a horrible number, saying that 81% of individuals diagnosed with lung cancer were diagnosed with late stage disease. However, since implementation of lung cancer screening and over the past 4 years until the 2018 data, we are down to 71%. That is a 10% change. These numbers don't change by themselves. And these are very difficult numbers for a population to change. And yet we've seen a 10% reduction. So if Colorado can start to move more from here to more here and more here, like in Kentucky or in Massachusetts or in Maine, we can start to see some of these other changes that are going to change population health and reduce the burden of lung cancer in Colorado. And I will close out there and turn it back over to Dr. Dyer.
Hello. Well, thank you, Jamie. That was such valuable information. And we're going to close this session up with asking Andy Dwyer to speak to us. She is the director of the Colorado Cancer Screening Program, and she will share some of her experiences. I don't know if we can hear you, Andy.
Ah, there we go. Sorry about
There
that.
you
Debbie. My computer is being a little crazy today. Can you see my slides all right?
Yes.
Okay, great. So thank you so much for having me, and I will be quick. I know we're a little bit behind today. And it's been exciting to really hear, I think, a lot of the national efforts and what's been happening from throughout the country. One of the things I'm excited to share is with our statewide screening program in Colorado that has historically really been connected to colorectal cancer screening. And about 2 years ago, we really expanded our work to consider implementation of lung cancer screening, hereditary screening, and connections with the breast and cervical program to really think about the role of evidence-based interventions, specifically navigation and uptake of screening. So for our program, which had about 10, 15 years experience working in the safety net clinic systems within Colorado, which include FQHCs, rural health centers, critical access hospitals, and then a bevy of faith-based organizations. We had an opportunity to talk about this expansion of lung cancer screening into the work. And I was really excited because we had two programs that actually looked at the implementation of about the 15 health systems that we were working with. One of those was Bruner Caritas here in Metro Denver, who really connected to the St. Joe's system, working very closely with National Jewish Health. The other system was working with us was Summit County Care Clinic. And that was a little bit before COVID, and with the implementation of all things COVID and reaction to the pandemic, we weren't able to fully implement. But working with National Jewish Health, we had a strong opportunity to think with our patient navigation workflows, team-based care, which I think has been part of the thematic from today. We were really able to look at how do we integrate eligibility, shared decision-making, and referral processes. So when moving forward, Debbie, does that
Andy,
move to the next?
Can you, it's not in presentation mode.
Let me see here. Hold on just a minute. Let me, I'm having a little problem today. Let me stop share really quickly. Hold on just a sec. Sorry about that, guys. Okay. Christy, is that better?
Yes, thank you.
Okay, great. So essentially, when we had the opportunity to connect with the Bruner Caritas team, what was interesting is they had also had a strong connection with National Jewish Health, where they were making the direct referrals for eligibility, oftentimes even if they thought someone was maybe had high PAC years, maybe had a possible lung cancer symptomatic type of a patient that was presenting. But what we asked the Bruner Caritas team was to really look at ultimately implementing the eligibility criteria, really looking at shared decision-making within their team, and then helping with kind of a decentralized approach in terms of working with referrals through National Jewish Health. And I would say, Debbie, I think it was interesting when we were implementing, just because I think National Jewish had already had this established relationship, but we asked to really kind of change the paradigm in terms of the team-based care and really have the primary care team at Bruner Caritas take on that role in that implementation of really so much of the front end. And what was exciting is really through the fall of 2020, through the fall of 2021, even with COVID happening and a number of factors that were moving throughout the primary care systems and that people were having to be very reactionary to, we were able still to maintain this infrastructure of looking at implementation of the workflows with the primary care providers, with advanced practice nurses, really helping do the integration of workflows and the shared decision making, and then making those referrals over to National Jewish Health, with ultimately patient navigators at both sides of the spectrum in terms of from the primary care to the radiologies team, and making those referrals, making sure that they come to fruition. What was interesting is that ultimately National Jewish did a bit of a chart scrub, and for the 340 folks that they did either in-person discussions with or over the phone, about 350 individuals or 340 were deemed eligible, but only a number, about less than half of those individuals actually ended up going through a shared decision-making type of visit within the primary care setting. So there was a substantial drop off with the number of patients once they were identified as eligible, really going through that next step, ultimately getting people into making that appointment and those referrals coming through and holding those referrals. Again, we saw a pretty substantial drop off there as well. And I know through that sort of idea of adherence, even at the beginning of making referrals through that eligibility, especially in this situation for medically underserved, the role of navigator and how we were going to really make sure the benefit of screening was definitely presented was something that remains difficult. And I think Jamie and others had talked about that messaging. But what I found really interesting is when we did have the 50-ish people who were identified for their appointment, over 80% actually were successfully navigated. And then you can see ultimately the outcomes for completed screens, number of lung cancers detected, and ultimately the lung RAS scores. So what I think it presented is, interestingly, through the qualitative implementation of educating the primary care providers, the advanced practice nurses really being involved in the shared decision-making, and ultimately that Werner Caritas has stuck with the implementation of this plan when they could easily, default to just making most of their referrals immediately to National Jewish Health, that we're definitely onto something. I think that's, of course, been the theme of today. We're really excited because I think this is one of the safety net clinic systems who has limited resources, but see the value, and we're going to continue to work with many of our program partners. And what that has really essentially looked like is we do have the funding. We have a 2-year extension on our statewide screening program and the navigation program. So starting in July, we were able to access additional funds for the next 2 years to continue to build out capacity work. And we know that not all programs can be a Werner Caritas where they go from a 0 to 60, where they've gone from realigning their systems and team-based care into a full implementation with a referral partner. But we do know that there's a lot of interest even with many of our safety net clinic systems, again, federally qualified health centers, rural health centers and the like, who've been very excited about building capacity. So at this time, with our 11 participating clinic systems, which is about roughly 90 to 100 clinic sites throughout Colorado, we've been assessing really what that capacity looks like. And if they're going to build in room for work in lung cancer screening, what is it that we need to do to support them through this program where we have mini grants, but also where do we need to go from a state perspective and informing our state cancer coalition, CCPD funding, many of you who are doing research. So what we know right now is even out of the 11 clinic sites, about 7 of the systems who have strong awareness of lung cancer screening guidelines, a little less than half report they're implementing some sort of screening or referral consistently. And at least 4 of them are interested in really doing a strong connected work with us in terms of building out lung cancer screening capacity through our mini grants program. We're really excited because I think we have some assessments that we've used through the FQHC safety net clinic systems that we're working with to really do this assessment for capacity. We've also started a bit of an ad hoc research programmatic team, I think, which is a bit akin to the lung cancer screening task force through the coalition, to really think about shared strategies and collaborative research and assessment building and capacity building within the state, that through our program partners through Kaiser, National Jewish, as well as University and many others. We're really excited about keeping this collaborative movement with the collaborative, I should say, where we'd really like to also continue to gather some more information about what interest and what resources it would need to take to really implement lung cancer screening capacity work. So Debbie, I'm going to turn it back to you. We just had a couple short slides just to give an assessment, but what I would say is it's been great to learn from all of the research that's happening, much of the findings from many who've shared today, to really think about the implementation side of this specifically for the medically underserved.
Thank you, Andy, so much. It has been just a day packed full of wonderful information. I'm sorry we've run over. We're going to make a little adjustment in our agenda right now because we have three very important people that are going to provide the patient outlook for us. And so we're going to move them up to the beginning of our next section where we're talking about looking ahead in lung cancer screening. And so I would like to invite Heidi Anda, Bonnie Ulrich, and Joe Abila to join us now, if they can unmute themselves and if they have their videos ready, we can see them on screen. And we really are interested in hearing today what a little bit about what their experience has been, and then also how they see the future for lung cancer patients and lung cancer screening, which has been our focus today, although you will hear probably a variety of different views. So thank you so much. I think we might ask Heidi to start. And Heidi and her husband Pierre are on the screen, and we welcome you. Thank you.
Hi, thank you, Dr. Dyer, for this opportunity to share my story today because it's a very different perspective. I would never be eligible for screening. I am a fitness trainer, health educator for 20 years, married to a primary care physician, and I didn't even have any symptoms 3 years ago, and this was an
So Heidi is frozen on my screen. Heidi, I don't know if she's frozen on others.
incidental finding.
Here we are.
General population. Oh my gosh. Did
You
guys-
froze for a little bit, but now we have you back.
Okay, so anyway, I'll let Pierre chime in as well, but, I want to know where secondhand smoke is going to end up on this criterion list. I mean, I've been told by many, experts in the field that secondhand smoke is really bad. And if you're, exposed to it for the first 18 years of your life, that still doesn't qualify you to be even considered for screening. And, radon, it turned out we had a very high radon level in the house, didn't have, information about that until after the diagnosis when we found all this. We've got family history, pollution. And I know right now we just want to focus on getting people who are eligible. And again, my big question is, where is the public health campaign and messaging? Please show images of hope and messages of hope. If I were eligible and I just knew what was currently out there, it would look hopeless to me. And I don't know that I would want to know if I had lung cancer. And here the three of us are today to show you that there is hope.
But my only ask is that as lung cancer screening becomes more mainstream and more of the public becomes aware of it, which is a great thing, that primary care physicians are going to get more questions by patients who come in who may not qualify but have other risk factors that are prominently articulated on sites like the EPA, the CDC. And I'm only suggesting that perhaps healthcare delivery systems or other public health systems provide primary care with some guidelines on how to approach these patients. My own personal view is that if a patient doesn't meet the current guidelines, but has several known other risk factors, that at that point, it no longer becomes kind of a population health issue. It becomes a shared decision-making process between the primary care physician and that patient. Guidelines don't necessarily make ordering low-dose CTs illegal for the primary care, but I think there's some value to, at that point, letting primary care physicians know that at that point, you're going to have to do the best that you can with that patient and determine at that level what may be the next best step.
And just one shout out here. It is Lung Cancer Awareness Month. It's November. I'm grateful to have everybody on the call here. Please reach out. You have more power than patients do to reach out to your local media and get a news story. Let's get some news stories out there about screening that is available for people who are currently eligible.
Thank you. And Heidi and Pierre, do you want to mention a little bit about our white ribbons?
Sure. These white ribbons that you see in my background, Bonnie's background, Debbie's background, those were born out of my frustration a year ago that there were basically no plans across the country from cancer centers to do anything for Lung Cancer Awareness Month. And that was my release. I asked Pierre to make me this big white ribbon that I could throw on my front door, scream to my neighbors, one of which is Dr. Finnegan, who lives across the street from me, and to let everybody know that anyone with lungs can get lung cancer, and let's start talking about this. It went viral, and now we're in 26 countries. We've made over 3,000 ribbons and counting. So thank you.
Yes, thank you. And Bonnie, would you tell us a little bit about yourself, please?
Sure. I was diagnosed with stage 3 non-small cell adenocarcinoma, the exact same diagnosis that Heidi had. However, I had a history of smoking. So therefore that, unfortunately, fortunately and unfortunately, open up some additional doors for me in that I was more eligible for lung cancer screening, and which was done by my primary, because he's been with me a long time. This has been my third bout now with lung cancer. So he did catch the lung cancer both times, once through a CAT scan and once through a blood test showing my CEA level elevated. But now it's the, you don't have to be or have a history of smoking to be diagnosed with lung cancer. And we're finding that there are just as many, if not more, people getting diagnosed that never were or doesn't have a history of smoking. And when I first got diagnosed, I felt guilty. I felt like it was my fault because I did have that smoking history. And I came to learn through my advocacy work, that's just not true. Nobody deserves to be diagnosed with lung cancer. And again, our thing, if you have lungs, you can get lung cancer. But what was amazing was you have Heidi, you have myself, two totally different lifestyles. Two different parts of the country, but diagnosed with the exact same cancer, we did the exact same treatment plan. So that whole, we do need to we have to stop people from believing that the only way you're going to get lung cancer is if you have a history of smoking. That absolutely, positively, 110% is not true. But what we need to do is we need to, and I know there was a lot of discussion about early screening. My center down here in Florida, they're offering $99 low-dose CAT scans to people with, and you don't have to have any history of smoking. You don't have to have, all you have to do is say, I want to get treated, I want to get tested, I want to get, find out, because the secondhand smoke, we don't have a lot of radon here in Florida, but a lot of secondhand smoke. People grew up in the 60s and 70s, the parents were smoking all over the house, nobody knew back then, that the secondhand smoke. So they started this $99 treatment. And it took off like a wildflower. I mean, it's really going with us. So, again, I'm just, I'm grateful that it was caught, even though it was caught at stage 3. I've got a lot of hope that, a cure is out there for us. And Heidi and I are going to be discussing this for years and years and years to come, and Joe. And but we really have to just get the word out there. We need the early detection. We need to try and get this nipped in the bud before it becomes late stage, before it even has become stage 1. I mean, there's ways of doing it.
Thank you,
And I feel
Bonnie.
like-
Thank you so much. We just so appreciate hearing about your experience and Heidi's. And now we're going to ask Joe to tell us a little bit about his experience. And are you on there, Joe?
I am.
Oh, good. There you are. Okay.
I've been here. Good afternoon, everybody. My name is Joe. I'm a cancer survivor. Fortunately, mine was caught very early, stage 1A, and it was kind of by accident, but my primary care suggested that I have a screening done since I had been a smoker for a number of years. Okay, I'm totally grateful to her. She's the one who brought it in the forefront, opened my eyes about it, and I've had 2 screens since, and they have both come back clean of cancer. One found something else, but we'll deal with that when it comes. And I am just grateful. My family's been a huge support rock for me. My wife, my children, grandkids, they're all on my butt. I am still having some difficulty weaning off of smoking. I'm not doing any nicotine, but it's hard, and I'm trying to deal with it. I get grumpy when I get a little aroused, you know what I mean? But the cancer itself is gone, and I'm totally grateful for that, and the team that I've been working with, Dr. Owsley over at Lutheran Medical, I work with Sharon at Lutheran Medical. They have been huge support. They give me all kinds of advice, insight on what's next, what to expect, everything. So it's coming along. Been a year now, cancer free, and I couldn't be happier about it. It's great.
Oh gosh. Well, I mean, these stories are just so valuable that you really do put a real face on all that we've been talking about today. It is a challenge, certainly, for all of our community to be able to bring everybody in to get the care they need. And gosh, I hope we can get our lung cancer screening expanded beyond just the folks that smoke. And so I think, we've got some work to do. If nothing else today, that's been one of our messages, that there's a lot of work to do, but we've got a lot of wonderful people to work with to get this work done. And it means so much to us to have you with us today and share your stories, because this is what it's all about. You are what it's all about, what we work on day after day. So thank you so much. We just very much appreciate you being with us. And gosh, you're certainly willing to, if you're interested, you are welcome to stay on. We're going to move on to more about looking ahead in lung cancer screening. But again, thank you so much.
Thank you.
All right. Well, it's a pleasure now to ask Dr. Betsy Risendahl to talk with us about the work that she's been doing at the University of Colorado. She's a cancer epidemiologist, and she's going to share some information about resources for implementing lung cancer screening programs.
Great, thank you, Deb, and thanks to the hardy souls who are sticking in this late on a Friday afternoon.
And I really appreciate, oh, sorry, had it accidentally put up at the end there. I really appreciate the opportunity to be on today's panel with all the great speakers. And I know we have heard a lot today about from Dr. Crofta and Flores and Stutz about and Irwin about all of the barriers related to lack of awareness, stigma, costs and coverage, primary care providers as well as patients unsure about what to do, and of course, social determinants of health and other barriers related to comorbidities. So we thought it would be helpful to leave you today with a few resources for lung cancer screening. So I wanted to share with you some resources for the patient and community, and we did an evaluation project that I'll tell you about. Resources for patient navigators, and similar to Dr. Crofta's disclaimer, when I use the term patient navigators, I'm really referring to any support personnel helping primary care or imaging providers to implement lung cancer screening programs, and also some resources for providers and program development. And you don't need to be scribbling down links or anything today. I wanted to share with you that we do have a new online toolkit that just was launched actually today. For today, we made sure it was ready. That contains links and all the information that I'm going to share with you. I put the link in the chat, and here it is as well. But this project was funded, the gathering of these resources and the production of this toolkit was funded by the Lung Cancer Research Foundation, and thanks to Erin Hirsch, I'm not sure if she's still on, and also to Jamie for leading and advising on these materials. So I had the chance to work with a capstone student in our Masters of Public Health program at the School of Public Health. And she helped us do an evaluation of patient education materials. And we used these 4 criteria here shown on the left. And we looked primarily at information that was available from advocacy organizations, national resources. We didn't look at individual programs or projects, some of the other resources that were shared with you today, but we looked at the domains of literacy, visual display, readability, and reading level. And these are some of the recommended patient education materials that we came up with. I want to emphasize that we did look at 10 or so different materials from multiple groups, and all were excellent and used non-stigmatizing language and imagery. These were just the few that rose to the top in terms of those indicators that I mentioned previously. So the Lung Cancer Project and GO2 Foundation have great materials that are available online as well as printable that could be useful for outreach, one-on-one patient visits, or in packets or health fairs. The American Lung Association has a great website that would similarly be useful for initial outreach. The National Comprehensive Cancer Network has shared really nice shared decision-making guide that could be useful in a patient encounter. I also want to encourage you, if you have other experiences with tools, that you feel free to share those in the chat and do a bit of crowdsourcing. As far as the toolkit that I shared the link with you earlier, one of the things that we did, and again, thanks to Jamie for his guidance on this, is we tried to take the best available evidence as shown there in the left-hand column, and then translate that into how you might implement that evidence in a program. So for example, recognizing that individuals who are eligible for lung cancer screening have a long history of tobacco use, and so that warrants the use of empathetic approaches, and that recognizing that screening presents a new opportunity for cessation. So we have these kinds of tip sheets spread throughout the toolkit that we hope will be helpful to you. Here's a list of other societies that, in addition to having information about lung cancer screening, that could be helpful for staff and patient facing. American Cancer Society especially has wonderful information about treatment options. American Lung Association has helplines. And then Smoking Pack Years is a great online calculator that helps with some of the difficult issues that Dr. Crofta mentioned in terms of trying to come up with an accurate estimate. Here's a list of other survivorship resources. Again, these are in the toolkit. all in the toolkit. And then as far as program development, here's some other resources where there's letter templates, questionnaires, workflow diagrams, such as the ones worked out in the screening program that Andy shared with you, the Colorado Cancer Screening Program. And then the American College of Radiology also has great resources on their website. Lastly, here's some policy and program level resources from the American Thoracic Society and American College of Radiology that might be helpful to those who are thinking about where do I start in developing a lung cancer screening program. A little bit more about the toolkit. This is the way it's organized. We have a readiness questionnaire embedded in there that would indicate to you where you might be in the process of implementation and suggested places to start with resources in the toolkit. And then also the Implementation Science Center that Jamie just spoke about, wanted to emphasize that this is a brand new online training program for primary care providers that's free CME credits inside or outside of Colorado, and 4 modules that are extremely well done. Here's how you would access those through our CU e-learning. But again, this link is also in the online toolkit. And then coming next month, we're wrapping up the development of an online asynchronous patient navigator training that will be located on the same website as the toolkit. So I wanted to thank the people who helped with the toolkit and the training, and for your attention today. Thank you.
Thank you so much, Betsy. That's just incredibly valuable information, very practical tools that I'm sure people will be very interested in using. Now we're going to transition a little bit to the Colorado Cancer Coalition Cancer Plan and the Colorado Department of Health and the Environment Strategic Plan. We have with us today, Allie Bain with the American Cancer Society and the current chair of the Colorado Cancer Coalition, Christy Cahill, which you've all been interacting with today. Christy keeps us organized as the director of the Cancer Coalition. And then Becky Seelig, which is the manager, who is the manager of the Comprehensive Cancer Program at CDPHE. So I'm going to turn the program over to them.
Thank you, Debbie. And we know it's Friday afternoon, and so we did have some slides that we wanted to share about the cancer plan and the different goals that touch on lung cancer related topics and some ways you can get involved. And so I put the link to the cancer plan into the chat, and so you can go peruse the cancer plan. It's goal 1, goal 4, and goal 5 are all have some lung cancer related goals. But the best way, I'm going to turn it to Allie now so she can tell you the best way to get involved with the Colorado Cancer Coalition.
Thanks, Chrissy. So we've kind of pivoted a little bit here, and I think our main plug to just wrap this up is let's just keep this conversation going. And I think the best way to do that is through our lung cancer task force with the coalition that Debbie helps lead, along with Morgan, Dr. Fenton, and Dr. Tim Kennedy. So if you are not already involved with the lung cancer task force, please reach out. Christy will put the information in the chat to get involved. And let's just keep this going. Thank you to all of our presenters today. Thank you to all of our survivors and that are currently going through treatment, for sharing your stories. This has been tremendous. Last year was kind of the beginning of it, and we're just continuing to keep this work going. So thank you to everyone, and please consider joining the task force here in Colorado to keep this conversation going. So I think we'll just wrap that up there, Debbie, and if you have any closing words for us, I'll hand it back to you.
All right. So actually, I'm going to turn it over to Jamie. And Jamie, if you just want to give us a quick wrap up and tell us your thoughts and where you think we're headed, and we'll follow you anywhere.
Well, that's awesome. I don't know if that's a good decision, but it's awesome. I want to follow up on what Allie just said, and I think the only way we make substantial progress here is doing this together. We started by talking about the multitudes of ways that lung cancer screening is a team sport. This is from our bioinformaticians who can help us design better ways to identify the people we target, to our screening programs, our primary care, our surgeons. Everybody, including behavioral and social scientists, including implementation scientists and policy people, we all have a really active role to play in implementing lung cancer screening and doing it optimally. But it has to start with putting the candidate and the participant at the center of the whole process. We are fascinated by the data. We are fascinated by what a low-dose CT scan can do, but that's not what this is about. This is about people and individuals and meeting them where they are, never so highlighted as by Drs. Irwin and Dr. Flores about what their work with mental health and individuals. We know that 40% of all cigarettes are diagnosed by, are smoked by an individual with a mental health diagnosis. That's amazing. So we know that we need to integrate that community in considering the potential for lung cancer screening. And the way we do that is through unity and teamwork and collaboration and support. We have a growing community of advocates who are firmly committed to raising the discussion of lung cancer policy, lung cancer screening, lung cancer risk reduction, thinking about new ways to engage our state and our nation in terms of leveraging this lung cancer screening opportunity. And that's what it is. It's an opportunity that we have to really make a difference, to make a change, and to bring greater equity by our focus on different communities that really need this. We didn't get to talk a lot about some of the other communities that could benefit from targeted efforts like the LGBTQ community today, but there are lots of reasons for outreach and expertise that can be brought and leveraged to working with these unique communities to bring the message of lung cancer screening, to put it on the radar. And I'll just close by thinking that lung cancer screening is part of the solution in terms of bringing together a greater supportive community around those individuals who are at risk for lung cancer. And to the extent that we can bring this forward, build more programs, build more access, keeping individuals at the center of the process, we can leverage this and we can create a kinder, warmer, gentler, compassionate community that is much safer and supportive for individuals who are either at high risk or who are actually experiencing this diagnosis and treatment. And we have to do that. This is a community that is unique and powerful and worthy of our support and our efforts. We have to rally around this technology and this opportunity to meet their needs and reduce this just horrible burden. So I think, I mean, you've stuck it out, you've dedicated your time, and now take that passion and get it out in the community.
Well said. Thank you. Thanks, everybody.